Good evening, faculty.
I will just talk to you in 20 minutes.
And delegates, good evening. Thank you for joining Shield Connect. I am Nishan Chawda, Regional Medical Advisor from Shield Healthcare. It's my privilege to welcome you all for this wonderful series, Trending Ask series, which is organized by AGOG, that is the Academia of Global Obstetric and Gynecology on Shield Connect platform. So in this task series, we will be covering the topic from A to Z topics. And today the episode H will cover the topic Hysteroscopy Simplified. So before we start with the series, let me show the short introductory video for AGOG. And with that, let me start the episode with small Vandana prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
With this, I'm happy to introduce the master of ceremony for this episode, Dr. Riddhi Desai and Dr. Jyoti Mali. So let me introduce Dr. Riddhi Desai, ma'am. Is consultant endoscopic surgeon and gynecologist practicing in Mumbai. Ma'am is West Zone Coordinator of Foxy Endoscopy Committee 2021 to 2024, Managing Committee member of MOGS, Youth Coordinator of MOX, Co-editor of Pandora, the PCOS Society of India, member of Youth Brigade, PCOS Society of India, and received many awards and prizes. And now let me introduce Dr. Jyoti Malik, ma'am. Ma'am is Medical Superintendent of JJ Institute of Medical Science in Bahadurgarh, Director of Roots IVF and Fertility Institute, GIMS, and Secretary General of Haryana Chapter of Indian Society of Assisted Reproduction, and Secretary of Haryana Association of Registered Obstetrician and Gynecologists, Joint Secretary of Delhi Chapter, ISPAT, Joint Secretary of HAG. So I hand over this sessions to Dr. Jyoti Malik and Dr. Riddhi Desai. Thank you.
Good evening, everyone. A hearty welcome to all of you for this webinar on Hysteroscopy Simplified. It is a task. Webinars are recurrent webinars which you have probably been following, and today we'll be focusing on H, and that is Hysteroscopy Simplified, dedicated completely to hysteroscopy. And today we are blessed to have amongst us all senior experts joining us from across the country, and I feel so blessed. Just with one phone call, they all have been here to guide us. And today I would like to first welcome Dr. Komal Chavan and Dr. Niranjan Chavan, sir, our conveners and co-convener for the task webinars. Dr. Komal Chavan and Dr. Niranjan Chavan, I think, need no introduction to the August gathering, but it is my privilege to be introducing them. Dr. Komal ma'am is a medical director at Chavan Maternity and Nursing Home. She is a senior consultant and a well-loved teacher. She has had a successful tenure as a chairperson of the Foxy Medical Disorders in Pregnancy Committee. She is the zonal coordinator for Foxy. She's the chairperson of the AMOX Family Welfare and MTP Committee, member of Managing Council of MOGS. She's the joint secretary of ISOPAB Mumbai chapter, premise secretary of AFG, national expert for Foxy UNICEF Lakshya program, national trainer for the Foxy Dhira and RAC project. She's the convener for Foxy Guinness World Record 2021 for Break Free from Anemia. And she has been awarded with multiple awards and accolades, amongst them Foxy N.A. Pandit and Dr. Shailaja Pandit Women Empowerment Award in 2022. We welcome you, ma'am.
Thank you.
And Dr. Niranjan Jawan, sir. He is the professor and unit head of Sion Hospital, joint treasurer of Foxy, and of course, president of MOGS, member of the Oncology Committee of SAFO, joint secretary of
Thank you.
AFG,
Thank you,
Dean
Riddhi.
ATOG.
Thank you so much.
Yes, sir. Yes, sir. Thank you so much to both of them. They have been extremely encouraging and they have always supported the youth. So we welcome you both.
Thank you. Thank you so much, Riddhi, for the lovely introduction. And at the outset, I welcome all the esteemed faculties for trending Ask the Expert series, that is a task series. Today's episode is episode H, and H is for hysteroscopy. And we are going to get it simplified with all the luminaries and experts who have joined here today. We have who's of hysteroscopy today, and it is going to be a really learning and an enriching experience. I am so honored that H also stands for Rishikesh Pai, our president Foxy, and he is one of the chief guests here, along with Dr. Pandit Palaskar, who is the guest of honor. Dr. Krishna Kumar, I think when we talk about hysteroscopy, we think about Dr. Krishna Kumar, and he's so kind enough to be the moderator. Among with all the luminaries, panelists, Dr. Sudha Tandon, Anurag Bhate, Nitin Shah, Jyoti Mishra, Bijoy Naik, Aditi Nadkarni, Saumil Trivedi, and Amrita Tandon. And then we are going to have fantastic talks by Dr. Milind Telang and Nozar Sheriar, which would be chaired by Meenakshi, Dr. Shakuntala, Dr. Monica, who is already joined, and Dr. Amita Shah. And our wonderful two coordinators, Dr. Riddhi and Jyoti, has done a fantastic job. And now I would like to take a pleasure to introduce our chief guest, Dr. Rishikesh Pai, President Foxy, the current president, founder and the medical director of the Bloom IVF Group, chief administrator of Foxy Manyata Project, Group Society Liaison of PIGO Women's Cancer Committee, editor of Indian edition of British Journal of OBGYN, editorial board member of Global Reproductive Health, board member IVF Worldwide. He has received almost 59, I think more than 100 awards, delivered 700 plus lectures, and I think 20 plus orations must have become 50 plus by now. And he has been cited almost 200 plus times, and he has been the president of so many organizations, ISAR, IAG, MOGS. And over to you, Dr. Rishikesh Pai. We are all eagerly waiting to hear from you.
Thank you very much. First of all, congratulations, Niranjan, for creating such a dynamic new academia of global AGOG. And Niranjan is a very dynamic person, and maybe, so of course, future Secretary General, and I'm sure President of Foxy, and maybe who knows what else in your life in the future. And Komal also, you have been dynamic, and we hope that you achieve your goals. You're working very hard. And we have got 2-3 very important. Pandit Palaskar, our president. Pandit President, president.
Yes, sir. Thank you.
Yes. And he is one great thing about him is that he has come up on his own hard work, and coming from semi-rural, of course, setting in now he's got a fantastic big hospital and all, great surgeon. And Dr. Krishna Kumar, another very, come from nearly zero, and now such a big hospital he has got. Jyoti Malik is there, and Riddhi, our Jyoti Malik, of course, is a very dynamic from the north, and Riddhi is there, who is, upcoming. I was seeing a biodata and was quite impressed by her biodata. She's achieved a lot in such a young age, and I can see a lot of other people in the audience. Dr. Nayak is there, Dr. Monica Singh, who did a great now ISAR conference just recently, and Dr. Jyoti Mishra, who is again a big endoscopic surgeon, again from Mumbai, but now we have lost her to Delhi. And then young people are there, like the Nitin Shah, who is no longer young now, quite a senior endoscopic surgeon, Saumil Trivedi, Amrita Tandon, and all illustrious Aditi Nadkarni and all this. So what I was telling you is that, I was very fascinated with hysteroscopy. So my first brush with hysteroscopy was when my thesis teacher, Dr. N.D. Motasha, did the first hysteroscopy workshop in KEM Hospital in 1984. So that time there was no camera. So I was there and in KMOT, and me and Dr. Mahendra Patel, who was the then Secretary General, had joined the score. So we had put the scope and he was saying, "Arey, bahut acha dikh raha hai." I said, "Sir, humko bhi dikhao kya hai." So, I said, "Sir, he had perforated the fundus and was seeing the bowel." So, but, and the bowel was nicely. So I remember, so I was very fascinated with hysteroscopy. And then somewhere in 1990, Alan Dishani came to town, and Lala Lajpat Rai, I remember, he showed us the resectoscope. For the first time, I was shaken, and I bought the resectoscope, and Dr. Rakesh Sinha bought the resectoscope, and he, of course, was crazy about resectoscopy. And by the time I had gone to IVF, so my thing was a bit distracted. So I used to do little resection and all. I had my own portable thing, but then I lost the touch. And then again in 98, I went to Bari for the first time. Stefano Bertozzi, I went there to learn. And every day 40 they were doing. There was no PV. All the residents used to sit there, and they were having 7 hysteroscopes. One by one, they used to do vaginoscopy. And I was there for 1 month. I went to the hotel. There was no English. So after 4 days, after seeing nearly 200 hysteroscopy, I had to use the emergency button. I told Dr. Bertozzi, "Sir, my mummy is not well," and I ran away from there. Because I learned so much in just 4 days' time. And I came and introduced, I remember Krishna Kumar phoned me, "Arey Rishi, kaun sa hysteroscope lene ka?" He doesn't remember probably. Now he's very big. But that time, I told him, maine wo time Versa scope buy kiya tha, Bertozzi scope buy kiya tha. So I did lot. Must have done 10,000-15,000 scope. And then, of course, now, when I was in my heady days, when I was very powerful, now though there are many IVF centers, but in those days, we were only 30 of us. So whatever we used to do, say the patient had to do. So those days, every patient before that, we used to do hysteroscopy. Now we do only, so nowadays I can't do like that. So because if I say a hysteroscopy, they'll go to someone else and get the IVF done without hysteroscopy. So now I tell them, okay, first time, if you fail, then after that, before the next transfer, I will do a hysteroscopy and then do the transfer. So I modified my way. So life you have to reinvent life as you go along. Remember that. But now you are doing fibroids. After 10 years, you will not be able to do fibroid because you'll have a technology where you inject nanospheres and they'll go and hit on the fibroid muscle. And when you give them radiation, and they'll kill the cells. So suddenly your laparoscopic surgery will disappear. So you have to keep on reinventing yourself. So just now my daughter she's in computers, and suddenly with ChatGPT, a lot of programmers are suddenly staring at joblessness. So they have to reinvent this. They have to go back to school. They have to learn artificial intelligence and then go into the artificial intelligence line. So don't think that life is static. Life is dynamic. Life keeps on changing. But at the same time, enjoy the moment. Enjoy the fun of hysteroscopy as it stands today. It's a wonderful tool. And the biggest advantage of hysteroscopy is it's a democratic tool. Any average surgeon can learn the technique, unlike laparoscopy, where you need a higher skill set to learn the technique. And the other thing I always feel very bad about, and I think this is for the professors, that all the students that come out now have to then get trained, which is not fair. I feel that if you have to, so we need to have more simulator training. If you come out of MD, you must know how to put the trocar. You must know how to remove a 5 centimeter fibroid. If we don't do that and don't train our people, we have failed in our training program. You just can't put out MDs with just doing cesarean and DNC and some chota. Even they can't do proper hysterectomy. So we have to, probably because the number of people have gone up, the residents have gone up. So we need to use simulators to teach them a lot of the things that they can't actually do. In the olden days, everyone used to do. But nowadays, with now the new regulation has come of hysterectomy and all that. So because of that, the work is going to go down. And so we will have to be more simulator trained. And also because the work will go down, you have to also move towards more preventive gynecology. Adult vaccine, how the pediatricians, they make money out of vaccinating children. So we have to start making money out of vaccinating adults. So We have to evolve an adult vaccination program. We have to go into cosmetic gynecology. We have to go into obesity reduction. We have to go into counseling. So these are new avenues of income which we'll have to open up. We can't just rely on the good old cutting. The cutting is going to go down, because if you do good old cutting, you may get litigated for doing the wrong kind of cutting, unindicated cutting. So already that's why the new rule has come on hysterectomy. So we have to be careful how you do it and take care. Don't do an unnecessarily intervention, because that can land up in trouble. Thank you very much, Niranjan, for inviting me.
Thank
And
you.
wish
Thank
you the
you.
very best.
Thank you. I want to add something, Komal.
Yes.
Yeah. I want to add here in 1991 when I was a resident in Siam Hospital and Dr. Khandwala was the IAGE president. Dr. P.K. Shah sir was the secretary, organizing secretary, and there of course, I knew Rishikesh since my UG days, but there, as he said, Alan Disharmi had come and Wamstaker had come, sir. I hope you remember that. The workshop which we did at Sion Hospital.
I know. Keith
Wamstaker,
Wamstaker had come.
yes, yes. And he had devised that hysteroscopy mat and he showed that demonstration. And I remember, sir, you showing transcervical hysteroscopic catheterization and the OT, it was shown and it was transmitted to our auditorium. So this was exactly 32 years back when I was the registrar, and that's how I have seen you grown up absolutely. And then we came to know about your rendezvous in Bari with Stefano Bertocci and the other things. But really, Rishikesh, you are an enterprising personality, and always, we like to just listen to your talk and the way you talk. The second person which I would like to quote here, Saumil is here, is your father. Once he starts speaking for 40 minutes, we just listen. And the second one, third one, I can go on, but really it is very inspiring for the younger generation and for us. And it gives a lot of impetus for to vision to see. As you rightly said, the dedication of professors have to be there. Hysteroscopy has to be taught to the residents. In our unit, we do so. All the second years, they have to perform hysteroscopy. Laparoscopy is done by a qualified person. There has to be knowledge about ultrasound, infertility, laparoscopy, and that is what you rightly said that just doing cesarean sections and just doing DNC, MTP is not the only thing, and that is what there are so many things like the system in North India, as you said, sir. Also, there are 3 years. You cannot become an assistant professor unless and until you have 3 years of SRship. That is also, very important. So, just doing an MD, MS, or DMB, MRCUG is not enough. What can I say about Dr. Krishna Kumar and all of them? They are really pioneers. And Pandit Palaskar, we have seen him growing up in front of Dr. Trivedi and Dr. Sudha Tandon. So thank you all of you for joining. And really, sir, with your busy schedule, we are all awaiting the Femtech 2 conference, which is going to be in Delhi, and the managing committee of Foxy, which you are doing. You have done a wonderful job, especially the uh, Yatra in North India, where you have covered more than 21 cities and 5 states, and 5,000 to 6,000 gynecologists you have touched. We have gone there into their houses, we have gone there into their institutes, we have gone there into the hospital. I don't think any president of Foxy, of course, I do not want to take names, but literally they have gone to their own societies. Usually, we have attended conferences where all of them come under one roof, but that's an amazing feeling which you have given to all of us, and that is what is Rishikesh Pai. You are individual, one person who is very different than others and always inspiring. Thank you, sir, for being there with us.
Thank you so much, Dr. Rishikesh Pai, sir, and thank you, Dr. Niranjan Chavan, for your views. And now we welcome our guest of honor, Dr. none other than Dr. Pandit Palaskar, who is currently the president of IAG. He's an gynecologist, endoscopic surgeon, IVF and ICSI infertility specialist. He is from the city of Aurangabad. He has been as a faculty and a guest speaker for many national and international conferences in India and worldwide, published papers in national and international journals, and trained 800 plus gynecologists from all over the world. And I think he has a very fabulous setup, which I've heard. And he is the one person in endoscopy, a very leading person from Amogs and Maharashtra. So over to you, Dr. Pandit Palaskar. We are waiting to eagerly hear from you.
Yeah, thank you so much, Komal Madam, for the kind words. Respected dignitaries on the virtual platform, Dr. Rishikesh Pai Sir, President of POXI. Dr. Pai Sir is always inspiring, and he always promotes the youngsters and the upcoming gynecologists. And I know since the last 25 years, he always behind the youngsters. You go ahead, you lead this organization, you be in these committees. So he is always a torch bearer to many of us. So he is a mass leader. That's what I see in his position. He touches so many people across the country and the world, and always a source of inspiration and torch bearer to many of us. Thank you. Thank you so much. Thank you. I must congratulate this brilliant and the lovely couple, Dr. Niranjan Chauhan and the Komal Chauhan. They are always in the academics, and their academic content is very good, and it really valuable to many upcoming gynecologists, the PG students and the practicing gynecologists. And this task series, I like this series, focus series, where the like-minded people, they come together and speak on a topic, and really that is very useful. So many people, the consultants and the seniors, they discuss the various issues of the subject, and that is really very useful in the day-to-day life for the practicing endoscopic surgeons and the gynecologists. Today's topic, the hysteroscopy, friends. Today nobody can practice the routine gynecology without hysteroscopy. Hysteroscopy has entered in all the areas, the routine gynecology, the menopausal woman, and we can't practice infertility without hysteroscopy. We require hysteroscopy for primary infertility, the secondary infertility, pre-IVF it is required, and management of the gynecological conditions like DUB, you require a hysteroscope. You can see and treat the pathology. It is like a stethoscope of the gynecology, like previously our two finger of PV are used like a stethoscope. Now we have evolved to ultrasound, and then now the hysteroscopy has become our stethoscope. So it has become a must tool for the all gynecologists. And today we have the all the experts from our country, Dr. Krishna Kumar sir, the past president of IIG, and we call him as Asherman of India. He has treated so many complicated and the large number of the Asherman cases, and he has taught the art of hysteroscopy to almost every endoscopic surgeons in India and abroad also. We have other stars also, Dr. Sudha Tandon, Dr. Vijay Nayak, and so many people are there. And really, this series will be very useful for the upcoming gynecologists and the endoscopic surgeons. We at IIG also, we are taking various training programs which will be useful for the PGs and the upcoming endoscopic surgeons. So do join IIG. And in this year, we have so many programs for the beginners, the those who are already doing, and for the seniors also, we have cadaveric courses. So in India nowadays, there is a lot of opportunities for the training in endoscopy, let it be hysteroscopy or laparoscopy. When we came into practice in the year of around 2000, there are very 2-3 centers who are giving the training in the endoscopy. Nowadays, with the advances in the knowledge of the endoscopic surgeons, with the advances in the technology, the learning platform, so many learning opportunities are there today, so that we need to spread the endoscopy in all corners of the country. It should not be restricted only to the cities, and we can see it has gone to almost district and taluka places. we have these facilities of the endoscopy so that the access to the minimal access surgery is on the broader aspect. So I thank you so much for giving me opportunity. Thank you, Riddhi and Jyoti Malik and the conveners of this program for giving me, inviting me and giving opportunity to be on this dynamic platform. Thank you so much. And I wish you all the best for this teaching program. Thank you.
Thank you. Thank you so much, Dr. Pandit, sir. It was really great hearing from you. And I know the IAG is doing such wonderful work, and all the training which is there in IAG, it is really going to help all the practicing gynecologists.
Yeah, thank you. Komal, can I
Yes.
say something?
Yeah.
You know, when you go to Endo World, you will find Dr. Pandit Palaskar absolutely mum, and his wife is talking to the patient and counseling. Even in the operation theater, if you hear Pandit Palaskar's voice, it is a divine interception which has occurred. He is a man of few words and he speaks very less. We have coaxed him many times that you speak, but he will just smile at us. That is his forte. But he is a very silent worker. You have to imagine because I have attended his Endo World conferences, and they not only that main hall, but all the halls are absolutely full. I remember 10 years back, 7 years back, when he had hold those Endo World conferences in Aurangabad, and he and you will find 60 to 70 stalls. All the whole world will be there in Aurangabad. And that is the magic of Dr. Pandit Palaskar. And we are very happy that he is there at the helm of affairs of IAG. And the work which has been started by so many luminaries of IAG, you have continued with that. And I'm sure the membership has also increased. We have Dr. Krishna Kumar here. First time, I think, in Asia, we have started that cadaveric courses, sir, and it has really got a lot of fruits and knowledge for all the the members as well as the students. So thank you, Dr. Pandit sir, for joining today, and of course all the faculty members who are present at task series. Task series was actually started to briefly give you an idea in 2020 when the COVID was there. And AGOG was started in 2019 in Bangalore, where I met all the members of Foxy, Dr. C.N. Purandare, Dr. P.K. Shah, sir, and we have all patrons from all the 5 continents. Linda Bradley is the medical director, or rather, she was in AAGL, and she has been, a proponent of hysteroscopy. She has also come in task series and attended our and given us all the benefits and for the knowledge. Our main topic is hysteroscopy, my stethoscope. So thank you, Dr. Pandit Palaskar sir and Krishna Kumar and all the luminaries who have joined today. Without much, we will go ahead now. And this was a very homely atmosphere. We are going to see the magic now of Dr. Krishna Kumar, who is going to do a hysteroscopy live and his case discussions. And everyone is waiting, and I wanted everyone to join, and that is the reason we have taken time. Please pardon us for the time which we have taken, but I'm sure everyone will be enjoying this series. More than 600 people are joined and registered for this program because endoscopy is such a thing everyone wants to learn. So thank you, sir, for all of you joining.
Yeah, so thank you so much, Dr. Niranjan and Dr. Komal, and our chief guest, Dr. Pai sir and Dr. Palaskar have already set the stage, and the magic wand is already in the hands of our moderator, Dr. Krishna Kumar sir. He has his hysteroscope, or the magic wand that we call it, and we have this panel discussion starting, and let's all gear up for this discussion, which is challenges in hysteroscopy. So for this, we have none other than Dr. Krishna Kumar sir, who's the Chief Consultant, JK Women Hospital, Fortis Hospital, Kalyan, He has been the past president of Indian Association of Gynec Endoscopists, and he is course in charge of IAGE cadaver course, AAGL, CSEEMIG course, and has many others, many centers where he has recognized for ICOG fellowship. Then we have the various luminaries here as our panelists. Dr. Sudha Tandon, a senior gynec endoscopic surgeon with an experience of over 30 years. Dr. Sudha is the director, Tandon Fertility, IVF and Endoscopy at Chembur, Mumbai and at Wapi, Mumbai. And she was the first to start a gynec endoscopy center at Chembur. And she has been performing all major, minor lab and hysteroscopic surgeries. She has been a speaker in various conferences, national and international, and a member of various societies. Then we have Dr. Anurag, Dr. Bijoy. Dr. Bijoy is the head and consultant, minimal SS and robotic surgeries, Manipal, Dwarka. He has 32 years of experience and is a life member of IAGE, ISGE, and has delivered many, many talks and has various publications. Then we have Dr. Anurag Bhate, who is Director, Shubdeep Maternity Endoscopy Center, and is an honorary endoscopic surgeon at Nanavati, Wadia, and Global Hospital, Bogart Hospitals. And he is also, his executive committee member, IAGE, and he is the treasurer of IAGE, he is president-elect of AMA. Then we have next Dr. Jyoti Mishra, Director, Gynae and Laparoscopy, JP Hospital, Noida. She is a dedicated endoscopic surgeon with 26 years of experience. She is treasurer UP IAGE and director of Excel Academy of Laparoscopy Training. She is a Foxy endoscopy trainer and a convener of various conferences of North Zone coordinator of the Foxy as well. Then we have Dr. Nitin Shah, who is recipient of the Golden Hand Awards and also the Wonder Foxian Award, and also the world record holder for removing the heaviest fibroid, a largest paraovarian cyst, and a hysterectomy in a male. So he's done more than 50,000 laparoscopies, and he is national and has international publications and trained many gynecologists. Then we have, next please, we have Dr. Amrita Tandon, also a fertility IVF consultant and endoscopic surgeon at Dr. Sudha Tandon Fertility, Chembur and Vashi, and she has been the MOGS Youth Council member for many years, 7 years, a member of various societies, presented various papers, and has received the Best Paper Award at FEM Conference in 2017 and also in the MOGS IAG Endo Art 2018. Many other awards I would skip for this because we are running short of time. Then we have Dr. Saumil Trivedi, another wonderful endoscopic surgeon, sonologist, and a urogynec consultant at.
खाली नाम ही काफी है.
चलेगा, हाँ, बस ये इसीलिए. So I will, नाम ही काफी था. We have Trivedi is the name. So then we have Dr. Aditi Nadkarni. इसमें भी नाम ही काफी है वैसे तो, पर फिर भी 2 लाइन बोलूंगी. She is a chief consultant Eva Care Fertility Vapi and a senior consultant also at 21st Century Group of Hospital Valsad and Vapi. So she has to her credit many, more than some 3,000. I could read out some 3,000. So, and we have Dr. Monica Singh, who's Associate Professor, Ellen Medical College, Bhopal, a Secretary of MP Chapter of ISAR and Vice President, Bhopal Obs and Gynae Society. And I would now leave it over to Dr. Krishna Kumar, sir, to start with his magic wand. Thank you, sir.
Thank you, Dr. Jyoti. Can I share the screen?
Yes, sir.
Yes, thanks to Dr. Komal Chavan and Dr. Niranjan Chavan for having me in this task webinar. And as it has been already said that we are going to have a focused discussion on hysteroscopy. And thanks to Dr. Rishikesh Pai for those kind words. And he has been told that he has been always inspiring. And whenever I think I should now relax, he says, no, you have to evolve, you have to keep learning. And that is what in hysteroscopy we have seen from what it has been taught to us 25 years back and where challenges are being thrown every day. When Dr. Riddhi Desai actually called me to do this panel challenges on hysteroscopy, I took it very lightly and I said I can definitely join. I didn't know, I thought I will have easy, it won't be very difficult. But when I saw the names in the final brochure, I saw such luminaries, all experienced hysteroscopic surgeon and laparoscopic surgeon. So it was a challenge for me to challenge these people with question. But then I thought that every challenge will teach you something. So I am taking this opportunity to learn myself from these experts. And I must tell all the delegates, let us sit back and learn from these experts, because a lot of challenges keep coming to my mind when I'm still doing hysteroscopy and I'm learning hysteroscopy. So welcome to all my panelists, and I'm sure they'll do a wonderful job. Well, before hysteroscopy, the big challenge for us was there was no access to intrauterine pathologies. We were always doing incomplete and blind treatment. And as told by Dr. Palaskar and many others, it has made us complete, and it is called the stethoscope. But initially there was reluctance from everyone to learn or to take to it. But still, should every gynecologist be doing it? And I'm sure the answer is absolutely that yes, you cannot call yourself gynecologist if you don't know hysteroscopy, because you can't tell your patient you have a polyp and I can't remove it. You can't tell a patient your abortion is due to a septum and I can't find how to go about it. So today, there is no way you can. But is it easy to learn and master it? That is what I'm going to ask the general, all the panel. And how to keep pace with the innovations. You know, what I learned 25 years back and what I'm still learning, every day something new is coming up. Challenges continue to rise. I thought I know everything in hysteroscopy, but the newer innovation throws up newer challenges, newer way, and you have to continue to evolve. So, and I can just distribute these challenges as two traditional challenges which hysteroscopy has. Hysteroscopy has the traditional challenges which we all know, and the challenges which are all due to this innovation which is coming up. And I would like to focus on these innovation challenges which are there. So I don't know how much time I have for this panel, 40 minutes or 1 hour. Riddhi? Okay, now hysteroscopy is a safe procedure. The complication rate is very low, but you must remember that the safety and outcome is linked to adequate training and adhering to safety recommendation. So my first question to the panelists is, be short. The first traditional challenges we are going to run fast. We don't want to waste time. We have now come to a conclusion what to use, what not to use. What are the challenges we as hysteroscopists or we as gynecologists face in hysteroscopy? Can one of the panelists tell?
Biggest challenge which we feel is with large myomas, submucous myomas, type 2 myomas, severe Asherman's, where there's a Dr. Jyoti Mishra here, and balancing the completion of the surgery with fluid balance. Fluid overload should be avoided. These are some of the challenges I think we all face. Major.
I think the challenge is also entering into the uterine cavity.
Yes, I think that's the main perfect entry.
Entry into the uterine cavity, unless
the main problem or complication in gynecology was blind entry, which we all had to do. DNC, yeah, the complication with DNC was so much false passage, perforation, incomplete. And that entry itself is the first thing, which is the biggest challenge for us. Yes, what said? So the anatomy of the uterus, one has to learn. We as hysteroscopy, we as gynecologists, we all forgotten the anatomy. I wouldn't go into the detail of it. And what else challenge? Yes. The second challenge?
Yeah, I think when you talk of anatomy, I think it's very important to identify, because sometimes even the ostia, whether especially in intrauterine adhesions or a polyp, small polyp sitting there, there are or in a unilateral, unicornate uterus. Sometimes you don't know whether it's really the ostia or what you're doing. So I think
right. Understanding the anatomy has been
anatomy and
something.
being very
So
sure. Yeah.
The
I
biggest
always talk about anatomy in hysteroscopy. That's a big talk. I always like to talk. And yeah, what, Soumil?
So the biggest thing is diagnosing most of the things before doing a hysteroscopy. So nowadays we have the technology, that is 3D ultrasound and everything, wherein, like we can preempt all these challenges in terms of anatomy and everything. And second thing, as Sudha madam and I think Anurag Bhatia rightly mentioned, I think in postmenopausal women, sometimes the challenge is entering into the uterus.
We are coming to that. We are coming to that. The traditional challenge I wanted is, of course, the distension, which we all know is the biggest challenge. Is the biggest challenge, because still many of us, or many of the conferences where I go, they say how to distend the cavity, how much is the pressure, and the whole complication of hysteroscopy is because of the wrong distension and the complication which it leads to. So now instrumentation have been evolving. What are the instrumentation to buy? What energy to use? These are some of the challenges, and what are the complications to be taken care of? So I would first ask, will you buy this instrument today? Sudha.
Sorry, what is this instrument? I cannot.
This is the traditional 25 years back hysteroscopic sheath. We had the diagnostic and the operative, the rounded one. The rounded one, the operative and the bigger one. This is the one which I started with. So today,
I think today this is
4.5 mm scope with the sheet.
4 millimeter, 4 millimeter.
This was the 4 millimeter scope, and the
with a 9 millimeter operative sheet.
Operative is 9
Diagnostic sheet used to be 7 millimeter. Will you today buy this? Because the new hysteroscopic surgeon wants to know what to buy. So the challenge is for us to advise what you will buy.
I think the time has come where the vision with the 2.9 mm hysteroscope is very good, and it is also not a rounded tip. And I don't think there is any need to buy a 4 millimeter hysteroscope. Of course, if you are in a transition phase, where you cannot afford the 2.9 mm, but I think and you have a good amount of hysteroscopy, so that is a different aspect altogether.
Very rightly said, one should not buy 4 mm now. I see so many bigger, even corporate hospital continuing to use the 4 millimeter telescope, which absolutely kills the hysteroscopy art. So you said rightly, 2.9 with the Betoki operative sheath is the one which you should buy, which is just 5 millimeter. Right. So we will go quickly to all these traditional challenges which we buy. Now, energy in hysteroscopy today it has changed. When I did hysteroscopy 25 years back, any surgery was always with that big resectoscope, loop, Collins knife, without which I cannot do anything. But today, we all say, what, should we buy resectoscope or not buy at all? Soumil.
Definitely buy.
Yes, bipolar resectoscope.
Definitely buy, bipolar preferably, but definitely buy.
Yeah, but I would say
but a smaller diameter, smaller diameter.
scissors as well. But definitely a bipolar resectoscope is a very, very good and useful tool to have while you're doing a hysteroscopy.
So I am happy that all the panelists are on my same thinking that bipolar resectoscope and not monopolar we should talk. I wouldn't go into the detail why, because of the shortage of time. And today, as I said, initially 100% surgery inside the cavity was resectoscopic, but today it is occupying hardly 15 or 20%. But you can see the cafeteria of telescope and the sheath which we have got now, right from 1.9 to 4 millimeter, the resectoscope varying from 26 French or 9 millimeter to 5 millimeter. So today, so much things. So the thing is, if I have to innovate, if I have to upgrade, how much to buy that is the biggest challenge. Which are the things I will buy? So can anybody tell? Anurag, you are an experienced. Nitin Shah is not there, but Anurag is also a big.
I think a 2.9 mm hysteroscope with the operating sheath you should have a set of scissors, a good grasper, and a bipolar resectoscope. I think that covers all whatever surgeries you're planning to do in hysteroscopy will be done with this.
Bipolar resectoscope, which size you would recommend?
So 7. I usually
Yes.
7.5. 7.5 mm, the total diameter, that is 24 to 26 French is good enough.
22 French.
Yes.
Only problem with miniaturization is that the scope degree changes. So the 8.9, 8.7 resectoscope, that is a 26 French resectoscope, had a 30 degree. When you come down, it is a 12 degree, and when you miniaturize further, it's a 0 degree.
0 degree, yeah.
0
So
degree,
that-
yes.
Sometimes
there is
that is a challenge because it
Yes.
might not be
No,
adaptive in all the situations.
over a period of time, you get adapted to the changing of
Initially,
the scopes.
initially.
Initially, yeah, there is an initial issue.
Yeah, Bijoy Naik, you are a robotic surgeon, great laparoscopic surgeon. What is your view on buying a resectoscope today?
Oh, I started with the 9mm one, and way back in 27 years before. But at present, whoever is buying a resectoscope, that ought to be very narrow, close to 15 French or 16 French, and it should have all the elements that to go in with, like your bipolar resectoscope and your even you can do the office hysteroscope with that also. And bipolar
Right.
one is always preferable.
Right, as
All
Soumil
the-
said,
Dr. Krishna Kumar, with a 15 French resectoscope, I would say there would be limitations if there is a big submucous fibroid, because you're
right.
so
Large fibroid,
large
you do
fibroids-
require the.
right. So
Right.
I think in those cases, or if
For
you
large
have oil-
fibroids, one ought to
I
require.
think, madam, the
Optical
key in
one.
hysteroscopy is the time in which you finish your surgery. So
That
the
is
correct.
moment your French starts going down, the chips become smaller and smaller, and you take more time. Although it's a bipolar
Yeah,
resectoscope.
for a large fibroid, yes, 26
Yes.
French or 9
So
millimeter.
26 French usually comes in picture for large.
Right.
Right.
Jyoti, what are the complications we are worried in hysteroscopy and we have to take care? Because that is a very reason why many of us initially didn't take into big hysteroscopy, because of the complications which occurred and which were catastrophic.
So first is entry. One may enter into a false passage and they may not
Okay.
find the true passage. So it is, once you are in a false passage, it is difficult actually to. because
False
everyone is
passage,
very-
perforation, yeah.
Yeah,
Then
so
other
first-
complication.
And then as you reach inside, yeah, perforation, failure of instrumentation is another aspect, I think I should say. And your anesthetist tells you fluid overload or embolism, air
Air
embolism.
embolism, yes, air embolism, perforation, air embolism, and fluid. These are the commonest, more dangerous, like air embolism, sudden death in the table. All we have seen, we have reported those things. So those are the very scary complications. Fluid overload inherent to hysteroscopy. I wouldn't go into the detail, but today, should we have uterine perforation? We should not have, I feel,
With
at
vaginal
entry.
small
Yes, we
diameter,
should
we
not.
should not have.
Right. So I wouldn't talk about hemorrhage, bladder, bowel injury, and endometritis. We'll go on to the next. How to avoid air embolism? Anybody can just be in short and tell?
Number one, multiple exchanges because of if you're dealing, see, air embolism is more of worry, especially when you're dealing with a large submucous fibroid or a TCRE, wherein the vascular channels are getting open.
Correct.
So the number of exchanges, it's always best in hysteroscopy, even if you're doing a myomectomy, to remove,
Perfect.
take out
Yeah.
whatever you can in one go, rather than coming out, going back in, coming out, going
Right.
back in. So that
Yeah.
is one of the tips. No
Purging of the
Treadling
tubes.
like a conventional laparoscopy or anything.
No
So,
Trendelenburg. Perfect. Yeah. Then
Purging of the tubes, I mean.
perfect. Yeah. So
air,
this
removing
is
of
rare.
removed from the tube.
Never Trendelenburg, air from the tubing systems, remove it. Repeated introduction, as Soumil said, these are three common factors which you should avoid and take care of. Air embolism will be almost, never be possible, never there.
Even to leave,
So-
once you're dilating or doing anything, leave the dilator in place.
Yes,
let
yes,
liquid
yes,
change,
yes.
or a wet
Yeah.
gauze.
So perforation. Anurag, how will you avoid?
So depending on what kind of surgery are you doing or what instrument are you using, you have to be careful and you have to be aware at what extent you are going to cut either a septum or removing the myoma or whatever you are doing. So that you have to set your usual limits. Whenever you go inside, you can just make a cut. This is the limit I am going to cut, so that you avoid that perforation.
Right. RCOG study said that the 55% of perforation is entry related. Means initially at the entry itself, you have to be careful. Procedure related are others, which you are telling. Yes. So today, no sounding, no dilatation before insertion of hysteroscope. That if you avoid, you will definitely have no perforation. Yeah, Saumil?
Sir, one other thing is, especially in postmenopausal women, many of the times the ostia is mistaken as a internal os. Because
Yeah,
the
I'm
uterus
coming
is
to that. Yeah,
small. The
I'm coming
uterus
to
is so
that.
small.
Yes.
That is, and
So,
that ostia, because the cornua being the thinnest section, which is just 4 millimeter, it is the commonest site of perforation.
yeah, so you have to start the anatomy right from the external os, follow those mucosal folds, and enter the oval-shaped internal os perfectly. Follow the fluid passage, and you will never have false passage or perforation. So, how to avoid fluid complication? Can somebody just tell in short before we move on to the actual challenges of operative scopies?
So this is
Thank you,
basically
sir.
firstly,
Yeah, Amrita.
sorry.
Yeah, Amrita, please tell.
Yeah, so it is important to to use adequate pressure. First of all, it should not exceed
What is
150
adequate?
about 100 to 150 millimeters of mercury. You should not exceed that. Always measure the fluid input and output. So make sure that you have bags that can measure, and also inform your anesthetist if the fluid deficit is exceeding a certain point. So if you're using normal saline,
Right.
maybe you could go up to 1500, but beyond that, tell your
So,
anesthetist and be
right.
yes.
Selection of the right distension device is important to correct. So,
Yes.
what will you advise today to somebody as to what to buy? And of
So
course, there
if
are two
it
things:
is,
they're selecting the distension media, and of course, the correct measurement of fluid deficit. But one advice I want you all to give: the right distension device, because I've never found anything right distension device. Stores had come up with that easy, but they withdrew after 4 years and they said that is not the right. I was made to believe that that's the right, but today I don't know what is the right.
Endomat, which we have been using for, according to me, because that is the
So
one
we are
which
still
I've been
using
using.
pressure bags, and that is
Hamburg
working.
Endomat,
We are
according
not-
to
Yeah, so which one to select?
Dr.
Which one to select?
Kumar, can I just make one statement here?
Yeah, please state. Yeah,
Yeah.
please, definitely.
You know, we always talk of the right intrauterine pressure and the distension pressure, but when we are operating, there is so much of leakage from the os. So what is the actual pressure where at that point where you're operating? I think there is no device who will measure it.
There is
So
a
even-
device, there are devices which measure intrauterine pressure, madam, effective intrauterine pressure. But
secondly, it has to be balanced between.
I think, madam, the pressure at which we get an adequate distension to operate, that's it.
That is what I was about to tell. So
That is as
there's no
as
point
simple.
keeping the pressure less and not being able to see the pathology.
Very true. Very true.
I think
So,
the
the two pressure bag, the Medex bag with the TUR set seems to be
Yes.
working wonderfully. And as rightly said by Anurag, the time taken in hysteroscopic surgery and the amount of fluid you lose in 1 minute, or you're pumping your 3-liter saline if you're using, within how many minutes it is getting empty. That is important. If it is getting empty in 5 or 7 minutes, a 3-liter means your fluid pushing is too much. So that's what I follow now, because I've never found a right distending device till now.
Right.
There is the pressure and the flow rate. What
Correct,
happens
yeah.
is invariably the flow rate is kept very high. So we
What
don't
will be the flow rate? What should be the flow rate in hysteroscopy?
Flow rate should be kept at maybe 100 to 200 max.
Perfect. Yeah, it is about 200 during operative scopy. Yeah, 200 ml per minute.
So the pressure to distend in a diagnostic scopy is hardly 70 to 80 mm mercury.
Yeah, so that's that. So that, as you all agree, that distending device is still a big gap in our hysteroscopy, which I don't know when we will get an answer to it, right? And right
also before starting, sir, one comment here.
Yeah,
Dr.
Nitin,
Nitin Shah
welcome.
here.
You were ectopic. You are in an ectopic, you had said.
Yeah,
Yes,
just
please.
finish the case. Just one comment here. Always we have a habit of preloading the patient before taking to the OT. So I always suggest in a hysteroscopy patient, operative, we never preload the patient with a RL or something. You know, that is very, very important. Ask your anesthetist not to preload the patient, because they preload, we push fluid from below and post-op they give in body and they push it into the pulmonary edema.
Okay,
So
that's
that is one take home that we should avoid preload.
Post-op, your IV fluid should be less, not preload, and even post-op.
That's a scope. Yeah.
Even
so
then
now,
you
as far
just-
as
And what Amrita was highlighting, anesthetists being aware, when you exceed something, to give a dose of diuretic as well.
Okay. Yeah.
Collectively,
So, distension media, I think there is no controversy today. Saline or ringer lactate should be the media of choice for whatever you do, right?
Right, sir.
Yeah. So I wouldn't go into the detail for want of time, but collect all. The fluid deficit measurement has always become a big difficulty. If you don't put all these sheets below, especially in cases like myoma or a TCRE, fluid will fall all over the OT and all over the cloth. How are you going to measure the fluid deficit? So I routinely put this obsti bag in bigger cases, in cases where we are going to have a lot of fluid usage. This is one thing which I have. Anybody else has any other suggestion?
Sir, especially in such cases, no, don't use those heavy soaking underpads, which we usually put below the patient, because it soaks lots of fluid and then you actually don't know how much is the deficit. So especially in such cases, just put a simple plastic Macintosh or a simple plastic sheet in the bucket and put a tubing in the outlet tubing in the bucket so you can easily measure it.
No, what I do is I put the tubing in the suction bottle. The suction is not on.
Yeah.
No, that is right. That suction bottle, whatever comes, easy to measure. But what
and
is
you should
falling
know-
out of the vulva and the
And
perineum
one
is
should
difficult.
know the capacity of your suction bottle. It could be 800 ml, it could be 2 liters. So that one should know. And from there, it goes into a bucket. So then there is a person who's there at the receiving end,
Correct. You have a dedicated person.
dedicated person to do
Standard
that. And also,
mat is
when
having a
you're
4
using-
liter, but
Yeah. Also, when you're using those, pressure bags, there is something which is left into the bottle. So that also should be calculated. And what comes into the bucket. So I think all these calculations, one should be training the people in the OT, the staff.
Sir,
How many
I want
days
to
we
ask
all talk of this, but actually how many of us, because we are rushing to OPD, how many of us actually do this calculation, except in very large
No. You have to do
Few things.
Yes, we have to
one
do
practical
the
thing I would like to say. One practical thing I would like to say is there is an outflow channel in the hysteroscope. Okay, you connect a suction tubing to that and put it in a bucket, separate bucket, not a dustbin, which is lying in the lower part of your OT table. A separate bucket, you keep the outflow open and you can measure very, very easily. You can just ignore little bit leakage here and there, but otherwise you will get a rough, accurate, idea about the fluid loss in that. And also we have a rule. We have a rule. Once you finish 3 to 4 liter of saline, we always ask anesthetists to give furosemide 10 milligram IV.
Perfect.
We always put a Foley for the operative patient. So as a prophylactic, after 4 liter, you give a furosemide.
Yes, that's
But
a
we
good
don't
point.
put folies in a
will-
daycare patient. We don't put folies. We give furosemide 5 mg or 10 mg, 10 mg.
for a very large, like if you're dealing with a large fibroid, sometimes
Fibroid,
20
Yes, this we are talking about operative hysteroscopy. Where we are dealing with pathology. This is not for the diagnostic or a small.
No, diagnostic, we are not bothered.
Yes.
We have
Now,
a pool of 6 liters.
we will,
Just
yeah,
out
we
of-
will move on to the next now. Of course, since it's the webinar, I cannot see all the panelists. Monica seems to be quite, is she in the panel?
Yes.
And
she's
please
there.
answer. Please answer. I may miss out the names, but
No, sir.
definitely.
I'm listening to everyone. And,
No. We want your contribution. What you do,
Okay.
like Nitin Nitin gave few tips. So those tips are important for delegates.
Just Dr. Jyoti,
Right.
she said like Dr. Jyoti, you said that you're always in a rush. Practically, you don't measure the fluid. What I do is, because you know what, when I'm in the OT, I just postpone my OPD in such a way that I don't have the pressure. We do the fluid measurement very accurately. We follow the tip that Dr. Nitin has said, that we measure the outflow through a tubing. And as soon as we exceed 3 liter of that 3 liter NS bottle, there is a, you know, there is an alarm thing that the anesthetist has to give the injection furosemide. So we follow that.
Okay.
Yeah, at this point, just one point I would like to mention, that to actually measure the fluid, after doing so many, you know, it's not going to happen in a septum, it's not going to happen by and large in an adhesion. It's only in this big submucous fiber that one has to be really careful.
Those cases selectively one can do.
This used to happen very commonly when we used glycine. I remember, sir, 7 to 8 years back, glycine was like every 4th case with glycine, there used to be pulmonary edema.
Right. Today,
I still use only glycine. But
I mean, glycine is so
I will not say
stable,
this for the delegates or whosoever is attending, but I
am also using. So no worry about that.
So how are we going to take care when we use glycine? Any tips, Dr. Somil and Dr. Anurag, how to take care when you're using glycine?
Can I speak? Yes, Dr. Krishna Kumar.
Yeah, Bridget.
Can I speak? Yes, I still use monopolar. It's very fast, and I am using monopolar all Collins knife and dissectoscope of 27 years. Even you see the Osama's videos in YouTube. He tells about bipolar, but he uses monopolar. That was the question I asked him. And monopolar is not bad, but you ought to have a
monopolar is not bad.
That is
but if
not bad.
Sir, in monopolar people who are using,
it's not bad. It's not bad, for if something medical legally happens, then there are safer alternatives available.
Right.
Then you can be dragged to the court of law.
Glycine has yeah. So today I think we should not talk about glycine. Those old timers you were continued to use, the beginners may not use glycine. That's what I would try to tell.
I'm very
young. You are no, but you are got a very senior person.
I think in
the pioneer who has taught all of us, so that's fine. So let us go back from glycine now. We go to specific cases, challenges which I face, which you all must be. Such septum are easy to cut, but you feel that scissors is enough for all septum, or you want to use energy in some of these cases?
20% scissor is enough.
Scissor is enough.
Only very broad septums, septums or anything.
What challenge I see many a time is I start off with scissor, but as I go up, I see sudden bleeding, and then I change over to the cautery. But by the time I remove and I put, there is blood everywhere, and it becomes such a big chaos.
So the biggest thing in hysteroscopy, any reintroduction of any other modality is going to disturb the vision. So select your tool appropriately is the biggest challenge.
Right. So when you suspect very broad septum, go ahead with Collins knife with the energy, correct, whatever it is. Correct. Okay. Thank you. That is what short question we are going to do. I'm not going to ask you how much.
Only one tip here. Once you are planning to switch over from scissor to resectoscope, keep your outflow open. The blood will flow from your outflow. It will not clot inside the cavity. Once you change,
the cut part of the septum is covered by blood. Yeah, the cut part is always covered by blood.
Yes, sir. But then, but if you keep the outflow open before removing, the blood will flow. Fresh blood will come, and once you so that will help in irrigating faster than removing the clot.
Or just when you put the resectoscope, just wait for 2-3 minutes. Wait for the distance.
Yeah, but it is still not as clean as beautiful as
I agree.
Yes, 100%.
Yeah, now this is one case which many of you all will remember in the recent IIG conference.
Dr. Kalyan was doing.
So this is something, a challenge which you don't see the end of the septum. But what you do, how do you do this?
With the L hook, you have to make a nick and lead the blood flow. L hook. And you presume you have your MRI or ultrasounds with you, so you have an idea about the direction of the septum.
Start from the lower base
Go
near
towards the
the
internal
cervix,
os.
internal os,
Yeah.
and then you start cutting on the side where you suspect. Once you can do a trans illumination and evaluate.
That the worst mistake I had made when I didn't know an entity called as Robert's uterus, जो बाद में आया था, was I put a laparoscope. I put an laparoscopic aspiration needle because it seemed like a communicating rudimentary horn. I aspirated the chocolate content, and with the guidance of the needle, I did the resection with the guidance of the aspiration needle pointing into the uterus. I did the resection. So that was at a time when I didn't know there was something called as a Robert's uterus. I wouldn't say that is the modality how it should be done, but just sharing a personal experience.
In cases, sir, usually in this cases, the septum is thinnest towards the internal os.
Just above the internal os.
Yeah. So that is the key point. If you dissect there, and then you will be more easily entering into the other cavity.
Okay. Here I prefer the energy. I don't like to do it with scissors. That is very strange.
Scissors will be parallel, whereas this is perpendicular where the way it should be.
Okay. Now we move on to polypectomy. How to do a polypectomy? Is it better to do with scissors and then struggle such large polyps? And today we have the intrauterine retrieval system. What I should use?
Scissors.
I'm told that don't use energy. But yeah, scissors.
Best is shaver.
Best is
shaver.
Yeah,
shaver.
If you look at the left video, the polyp I cut, but now I couldn't remove it. How to remove that polyp?
Slicing technique.
No, I have cut it from the base. Now how to remove it? I couldn't slice. I couldn't do.
Dilate a little more, put a worm and take it out.
Yeah, but then during dilatation, I perforated.
Then you can see, put a simple grasper.
Use MVA syringe. Use MVA syringe. Manual vacuum aspiration
Just let a
syringe.
small part of the stalk attached. Once you cut most of it, small stalk you leave, then take a grasper and pull it out under vision.
Okay.
No, what you are supposed to do is whenever you see a polyp,
larger which is bigger than internal os, I think slicing.
You have to slice it. You have to
slice it. Yes.
You to slice. Technique is very important. You
I
plan.
bought a tripod grasper. I bought a tripod grasper from a conference. It's got the 3 pods.
The same thing which I showed you here.
So
This is the tripod. Can you see the tripod here?
Yes.
Yeah.
Madam, for a thing which is extending beyond the internal os capacity, even the tripod grasper will just come out and
slip.
the polyp inside.
Can I just add that most of these polyps, dilatation is a cakewalk. You will not perforate because the internal os is quite open. So even without dilatation, the ohm forceps will go and it will come out. You put your resectoscope or whatever hysteroscope you have inside, see whether you have taken out, but it should be taken out completely. So you have to have, I would rather do with a resectoscope because I don't have a shaver. And but with a resectoscope also, it might not come out completely. So you can use an ohm forceps, an excellent instrument.
Correct.
You know, it will just walk inside. Your ohm forceps will just walk inside.
Madam, but for postmenopausal, I just recently did 2 days back.
Not for postmenopausal.
Postmenopausal query, cancer, large polyp, it does not, it's difficult to dilate. So sometimes
we are coming to that.
I'm not talking of postmenopausal.
Yeah, we are coming to that.
Big hassle. Yeah.
Now, severe intrauterine adhesions where internal os is absolutely invisible. How are we going to proceed further? Do you use challenging sonography or something? Or how do you do? Bijoy, how do you do?
You can use the scissors how you're using, or even your grasper you can put and just, try to open it and try to, negotiate your way. Because otherwise
Are you in the right plane or right passage?
Sir, where the cervical rugae meet, that is the point where there will be the interlos.
You wait at the internal os for some time. Let the water seepage inside the uterine cavity. Once the uterus is distended, and you get some gray zone, gray area, denoting that there is a cavity behind. You just poke your scissors, open up, and then slowly walk inside the uterine cavity.
I call that as the gem point, where the mucosal fold meet.
Mucosal fold. Yes.
Yeah. That's fine.
You
Okay.
don't have to cut even with the scissor. You can just go a little
Yeah.
bit, keep on opening the scissor, and you might find the cavity.
Right.
Okay. Now, myoma, I thought I have mastered by the by the resection. But today, I heard a webinar last year, resectoscopy is having slow death. Go for intraarterial morcellation. And Dr. Sergio and others have started subcapsular enucleation. So which is the right way to do? What I should do now?
So cost is a major hindrance in morcellation. Everybody would love to have it, but cost is a major hindrance in having it.
No, apart from cost, leaving the cost, do you think it's a wonderful instrument?
Good for
And
grade 0
if
and
I give you free, you would love to have it?
so grade 0 and 1, it would be nice. 2, it would be challenging. It
It's a
can be done, but 2
Yes,
would be
yes.
There is opium technique wherein incision was made and in second sitting surgery was done so that the fibroid gets downgraded. Sergio Amovich sir went one step ahead wherein he just
this is
inserted
what
the
you are
capsule
seeing here.
and left it for it to
Enucleation.
be extruded itself. But
So-
I feel there is a lot of pain, cramping pain and bleeding if you just leave it.
Yeah.
So what could be the right method as of now?
See, in India, we need to go for the complete surgery in one setting.
Single
We
setting.
can't single setting. Our patient won't afford 2 setting, or we say I'll just cut right now and come after few days or few months. It is not accepted. So resectoscopy still hold very, very good. With the bipolar saline resectoscope, I think we can deal majority of the submucous fibroid, including G2 types, and we can have a complete near enucleation.
Dr. Krishna Kumar, can I add here? Now,
please.
Resectoscope slow death, probably it will have a revival after some time. They have problems with this.
No, sir. Sir, one more thing which I love, one statement from my father. Okay, I'll acknowledge my father in this. Ki hysteroscopy is one surgery wherein you can leave it at any moment.
Anytime. Yes, perfect.
So even see if there is fluid overload, there is a 7 centimeter myoma, you have resected 5 centimeter. If fluid overload is there, stop it.
Yeah, there is always a second day.
So second
Another
day, sometimes वो second day का जरूरत भी नहीं पड़ता है.
No,
So
but a septum
that
you
is
cannot leave halfway, na? A septum you've done partially, you can't leave it.
septum.
Patient will come back with
I'm not
another-
talking about a septum, madam. Septum, no one leaves.
Fluid
out.
overload, fibroid is
I'm not
usually-
talking of a septum or anything. I'm talking for a large fibroid which was targeted hysteroscopically, wherein probably GnRH was given, wherein something else was given to downsize the fibroid. Now, downsizing about medicine also, you cannot target ki only submucous part will get reduced and the intramural part should not get reduced.
Right. Now, the hysteroscopic surgery, you can stop anytime and restart anytime later also. Next day or after 10 days, anytime. Yeah, that is the advantage. Now, of course, bigger fibroids, difficult fibroids, Nitin, Lasmar 8, such lateral large fibroid, what would you recommend? Should it be done hysteroscopically or should not be done?
A combination is better. You start hysteroscopically. If the angle between the fibroid and the uterine wall is obtuse, most of the fibroid is into the myometrium and above. So do a laparoscopy and try it. If it is more than 4-5 centimeter, remove laparoscopically. If it is a smaller fibroid, less than 2 centimeter, one can attempt from below after putting vasopressin from the top. But it is going to be a challenging case. It's not going to be a cakewalk.
Yeah, so
I think everyone should set a limit of what size of myoma they usually do. So 3 centimeters is usually cut off in hysteroscopy. Yeah, personal
limit, not guideline limit.
Yeah. Okay.
Also, how much of it is, how much of the fibroid is far from the serosa? I think if it is just touching the serosa, I think it is
type O and 1 are fine, but problem starts from type 2.
Type 2. This type 2, which I
Basically, if we look at the residual myometrial thickness, if the residual myometrial thickness is less than 1 millimeter,
especially the
better to
lateral
approach
wall.
laparoscopically.
Especially the
Yes.
lateral wall, because they extend to the
One
anterior wall, they
millimeter
extend to
is
the
for
posterior
straight.
wall. Yeah.
Yes.
So it's better to put a laparoscope and remove laparoscope.
So the resectoscope challenges. Yeah, you are telling resectoscope. Soumil, what are the challenges you face in resectoscope?
Resectoscopy, sir, basically now because of miniaturization, quite a few things are.
No, during myomectomy.
During myomectomy resectoscopy, the basic challenge is the chips.
Perfect.
If you're doing a large myoma or anything,
So
like
how to avoid that?
the basic technique is very important in this. First and foremost, never withdraw the camera outside. Keep resecting. Once you have taken out a chip, push it forward. And again you have to be able to like take large strips at one go, not just the 2.5 centimeter which the resectoscope is giving you the capability. You have to move the scope as well, so that you get larger chips. Other than that, sir, mainly
Nitin, any tips apart from whatever Soumi
Sir,
just
what
said?
happens when you can go and remove the chips diagonally. You just take a few dummy stroke and go diagonally. You get a longer chips. Once your chips are getting cut, the fluid pressure which is coming straight below the telescope will push the chips away from the vision. So take advantage of that.
The other thing is, if you're dealing with multiple fibroids, obviously, like doing, if there is an anterior fibroid and a posterior fibroid, anterior fibroid is going to gravitate if you start resecting it first. So always do a posterior fibroid first and then do an anterior fibroid.
Right.
Also, I think, but it's also again important. Hello.
There is a lot of echo.
Yeah. I think in these big fibroids, or knowing where it is, whether it is anterior or posterior, I mean, you should be very sure. Sometimes a big fibroid is just projecting into the cavity, and you have to be very sure whether it is anterior or posterior. And then when you come to the base of the fibroid, it's at that time you have the fluid overload. So you have to be very cautious at that time. So I think that is the time you can have a perforation, and you can also have a perforation with your own forceps to remove the chips. Because it's big fiber.
Right. All those
Even
things
with
are
your
right.
own forceps,
Most of
you
the
can have
time
a perforation. So your
I think-
laparoscopy trolley, of course, should be ready.
Yeah, we will move to lateral metroplasty. What are the challenges, Monica? Do you feel lateral metroplasty? Should it be done?
Sir, I'm not a very big proponent of lateral metroplasty because the evidence is very conflicting. There is one school of thought says the old timers that lateral metroplasty, increases the size of the uterine cavity, gives that endometrial scratch. But then personally, I did not find any difference in the results. I did a small study of 25 patients each. I mean, I didn't find any significant result. But of course, if there is a straight edge on one side, I sometimes give a small cut with a Collins knife or something if I feel it is indicated. But I'm not a big proponent, sir. Maybe other panelists can give their experiences.
Sir, one thing I would like to highlight, I'm not a
Actually,
very
with the lateral, hello.
Yes, sir, Bijoy, sir, yeah, please.
Yes. With the T-shaped uterus, when you are cutting the with scissor or with any kind of energy sources, you are not increasing the size of the proper uterine cavity. It may be you may be cutting at the level of the isthmus or something else like that.
So you have to select the right case.
Dr. told.
Yes,
Sometimes
you have to
the
select the
right
right.
Sir, in this, I have a personal comment. Lateral metroplasty is one thing which I still prefer using a Collins knife only. I'm not saying it is the right dictum.
No, you are right. You are right. That's the only.
It is so swift and so fast.
Yes, Soumil, that becomes very precise.
It is so swift and so fast. 1 second में हो जाता है lateral metroplasty.
Because you get the proper angle with it.
Yes, correct.
So I beg to differ. I prefer
Anybody
using
can
a
beg to
scissors
differ. Anybody
for
can beg
lateral.
to differ, but
No,
lateral
with
metroplasty
scissors.
is one thing which I
Soumil,
feel if
Soumil,
actually
I've been doing
indicated, it
with
is with Collins
scissor.
knife.
I've been doing with scissor. Lots of lateral metroplasty. The problem only comes with scissor is one side you can do very easily after digging in. The other side it becomes a little problematic because only one end of the scissor moves.
Right.
So for
Perfect.
lateral metroplasty, the Collins life is always preferable.
Just a personal opinion, sir. Just a
No, I
personal
agree to that.
Small point in this, giving the patient a very good lithotomy and having those Allen stirrups helps so that you have that extra
Allen
space.
syrup for hysteroscopy does not have any difference, Amrita.
I mean, like when you give a very good
No.
and
See what happens, the movement of the
basically
hysteroscope, what
the
Amrita is trying
movement
to
of the
tell.
How Alan
the
syrup will
blade
help?
which moves.
No,
Okay.
she's saying just to give a good lithotomy.
So
Think that-
identification,
Basically a lithotomy
identi-
so that you have that extra space to go on the lateral wall.
Not the
Sometimes it is
modified
tricky
one.
to kind of dig into one side of
I
the.
think it's simple as you keep your hysteroscope at internal os. If you see the ostia, then you don't need to cut. If you don't see the
no,
ostia,
but
then you make
do
cut.
you all do 3D sonography to identify true T-shaped uterus as told by Bijoy Naik, or you all don't do?
Yes, sir.
I do, sir. I do.
I'm a big
Yes, that's a must.
supporter
That's a
of
must.
3D, 4D.
I
I
do,
do.
So you have to
I get it done.
identify the true T-shaped and then only do the lateral metroplasty. That's what the message is. Anyway,
Yes.
we will rush to the few slides. I won't go because I wanted to go to the newer challenges which I am facing. So I will not go into the elderly. I'll straight away. This is a 70-year-old, previous 2 seizure, postmenopausal bleeding, DNC attempted, cervix not visualized, eye placed, uterus adherent to abdominal wall. What next?
Vaginoscopy.
Vaginoscopy, yeah.
Totally down. You'll have to go to look up. Your hand has to be really, the patient has to be.
Yeah, this is rightly said, Jyoti. This is what was the case. You can see the way with speculum, you couldn't see this. Whereas with the vaginoscopy, you could see the cervix and you could enter and you could see a nice single polyp. So that is what I think should be the message, that you can do in any patient, you can do vaginoscopy and do hysteroscopy.
Right.
So we will move on to the
Yes.
In these cases, I usually prefer to do the cervical.
newer
right
challenges. Newer challenges which I face. Car pregnancy is on the rise. What are the indication for hysteroscopic removal of car pregnancy?
Like
ectopic?
myometrium thickness is more than.
Precautions to be taken.
Yes, sir.
Can
When we have
anybody with-
adequate thickness of the myometrium, then one can go hysteroscopically when most of the bulge of the tissue is into the cavity.
What is the adequate thickness?
By ultrasound, you can make out whether the scar ectopic is intrinsic or
The adequate thickness is 2 millimeters.
yeah.
So would you prefer to use the receptor?
3 millimeter.
But it should be done in endogenic. It should be done in endogenic one.
3 millimeter.
Yeah.
So you will use the intrauterine morcerator, or you will
What
use the
we
receptor
routinely
scope?
do is,
So whatever we have, whatever device we have, usually oscillator is not very
sir, I would like to add something here. What routinely we do is, whenever there is an early intrauterine pregnancy with a high beta HCG and a good vascularity, give methotrexate and do serial follow-up. Once the
Correct.
vascularity is reduced on color Doppler beta HCG falling, then you can go ahead with the hysteroscopy. Look for the
Yeah.
residual myometrial thickness. If it is more than 3 millimeter, you can safely remove the pregnancy product from below after giving methotrexate, and it becomes absolutely bloodless. No blood required, nothing is required. If it is a
Yeah.
bigger pregnancy and residual myometrial thickness is less, one can go put
No, Nitin is outside
Nitin.
somewhere.
Sir, I'll add
Signal
to
is
it what
poor.
Nitin is saying. Just go inside and with the cold loop, just scrap out the entire tissue. And most of the time, it doesn't bleed.
on the top.
Nitin, your signal is weak. You are outside. Yeah.
Please. No, yaar.
Yeah.
Okay.
So anybody to add on this car ectopic, what they do specifically, Monica or Jyoti?
Sir, if she wants to conceive in future and the thickness of myometrium is less, we'll go laparoscopically and do a good repair of the margins.
Scar tissue. Yeah.
Right.
Whatever method you do, there are almost 32 methods to deal with a scar ectopic pregnancy. But the study says the best is laparoscope, second comes HIFU.
HIFU.
The chances of complication is less with the laparoscope, and second is HIFU.
Okay. Now, moving on, I have been told that to use intrauterine morcellator even for all pregnancies, all intrauterine products of conception. Don't use anything blind DNC. What do you all say? Should we use hysteroscopy routinely for all retained products of conception, whether post-abortion, post-delivery, and
No,
how
sir.
to remove it, whether with intrauterine retrieval system or any other way?
So one can use resectoscope as a cold knife also in these cases. I had presented a paper. I mean,
But
those patients where DNC has failed, blind DNC has failed, we get a lot of references. So we look in and then as a cold knife, we just scrape them gently.
Sir, half of the patient will be reported as a AV malformation in such case
Sir, I have
because of the high vascular rate.
I have resorted personally to such cases wherein there was a uterine anomaly, wherein there was a diadelphic uterus or something of that sort, wherein there was retained products of conception after giving medical treatment, which was referred to me. So in that situation, I do feel it has a role. And in that also, I don't do hysteroscopic retrieval. I will just go identify the cavity because sometimes the cervix is only so deviated that, you cannot identify it, where exactly it is. In a diadelphic uterus or something like that. So it's my limited experience, sir. But other people can add. So I have resorted to hysteroscopic removal of POCs in maybe, I would say 8 to 10 cases. That's it.
So future, does it true that we should be doing only hysteroscopic?
I don't think so, sir.
Sir, I think
Guidance is good enough.
Monica, yeah, Monica.
Sir, I think hysteroscopic removal of products of conception is maybe we can do it in private setups, but in the large community setup, it's not feasible. There, it's better you do a careful curettage under ultrasound guidance because nowadays everywhere you have an ultrasound machine. Just put keep a partially filled bladder. Put an abdominal probe your assistant holds, and you can easily guide your this thing. This is for the the basic setups. But ideal would be to this. And another thing is the AV malformations are over-reported nowadays. Like nowadays, left and right patients are taking the MTP pills, and then they come with the retained products and the foul-smelling products, and that area becomes hypervascular. So I'm thinking in my ultrasound classes, we've been taught like all these the vascularity you see on power angio is actually not an AV malformation. So it is over-reported. These are just the products with the
Thank you. Thank you for suggesting the sonography also. But isthmocele, we get a lot of isthmocele now. Does all isthmocele require correction? What is the indication again for hysteroscopic and what are the precautions? You can see a beautiful
Only
isthmocele.
symptomatic isthmocele requires the treatment.
Yes.
Asymptomatic will not require.
Ischemocele are actually more a consequence of the single leg closure in C-sections which were being done. A lot of C-sections were done with single leg closures, and we also did a lot of them. So these patients, they usually present with this brownish discharge and intermenstrual spotting. Now, if the patient is really genuinely worried about this, then you might have to do a repair, and that would be best done laparoscopically.
Madam, but there is a school of thought which said that isthmocele hysteroscopy is the best. Osama propagated hysteroscopy. So any experience, who has a good experience, Vijay or Nitin?
Sir, hysteroscopically, if you want to correct the residual myometrial thickness.
Yeah.
Sir, adenomasses as well.
Isthmocele will be better option. But it should be done with all symptomatic cases.
Only symptomatic.
Sir,
if the patient wants future,
sir, it all depends on patient require future fertility, residual myometer, laparoscopic correction is warranted.
Yes.
Go for the hysteroscopic correction and remove
Okay,
the
if
region of
hysteroscopically,
blood.
what are the ways to do it? How is
Where
the
that you are
steps?
weakening this.
What are the challenges you will face if you have to correct
We can
hysteroscopically?
we can just remove the arch.
Yes, you have to just flatten those edges so that the deep trough of the isthmus becomes flat. She doesn't have any collection there. That is important in hysteroscopy.
And at the end, you just do a coagulation mode also and try to burn all the vessels over the isthmocele. That will help. That helps a lot rather than just put a coax current because we will be cutting with a pure cut current. And when after finishing the procedure, just rub with a coax current and it will take care of the post-operative spotting also.
Sir, if I may add just for 1 minute, we have seen in hysteroscopy this cesarean scar defect so many times. Never have we thought of correcting it. Now, if there is I'm telling you, I'm a person very limited experience of hysterostomy. I have practically zero experience. So I'm just asking a question to the panel and the moderator. That 2 centimeter isthmosele was right now reported to me in one of the patients. 2 millimeter, sorry, 2 centimeter.
2 millimeter, you don't have to correct. You don't have to correct it.
So you know, like someone advised surgery to that patient.
No,
and
no,
I blanketly said that there is no requirement of surgery.
No. As Bijoy already said, only symptomatic patients and patients who are infertile and as an isthmosele has not been able to conceive second time, then you may think. Otherwise, 2 millimeter doesn't require at all. Okay, this is now almost coming to an end. We are also coming to our end, our time, I think. Thanks. And of course, the most important, I'm sure there is a talk by my friend Milind. How many of you do ambulatory office hysteroscopy? And what are the challenges you face in our country in doing office operative hysteroscopy? Monica, do you do office hysteroscopy?
Yeah,
Amrita?
I did try operative office hysteroscopy. I do have a setup, but sometimes the OT setup is more convenient. The challenges we have is whether it's feasible or not. The patient also feels and the clinician also feels. Second, you sometimes feel
you may not do it in your office, but you can do it in your OR without anesthesia, like I do.
So this beautiful study by Dr. Clark's in UK, like it studied the...
She is awake and I am using the resectoscope.
Yes.
So what are the challenges in India you think we face?
Sir, it's never an office.
Complete and the pain.
I would call it an ambulatory hysteroscopy, not an office hysteroscopy. Okay.
We do it, sir, in a very, very high risk cases. We do it in a cases where anesthesia is contraindicated, aged patient, some medical comorbidity. And if required, we do real office hysteroscopy where the patient is not given any sedation. I think just as we just put a scope and remove with the scissor and...
Yeah, in OT.
In the OT, but without anesthesia.
Patient is not convinced if we don't give him the anesthesia, something we have operated on.
One can give paracervical pinocan.
Okay.
The concept of office hysteroscopy, according to me, in India is not very reproducible because I don't think anybody has an office wherein they can do, you know, like a sonography room. They have a hysteroscopy room wherein they
Milind Telang will show you his office setup immediately. I'm sure.
Sir, you are one of the exception. I have seen your setup. So you are one of the exceptions. There are few exceptions in India, but technically,
no, should be, because the world says move on to ambulatory hysteroscopy. So should we all move on? That's what I'm asking the panel.
We should try it.
For basic cases, yes. For basic cases, maybe.
Amrita, you are
I have not done it personally. Always under anesthesia. I feel convincing and counseling the patient is very important. And I've seen you do it. So
Krishna Kumar, it's very difficult to do with Indian ladies because they are more sensitive, I think, compared to the European ladies where Batoki and
right. Now, I'm sure Dr. Milind Telang will have more tips to tell us. We will listen, and I must thank. I'll finish this panel today, and thanks all the panelists for giving wonderful answers and clear-cut messages. So you have to master hysteroscopy, never dilate the cervix, never change to miniature hysteroscopy, use less of resectoscopy, surgery, and don't neglect the basics, anatomy and fluid dynamics. Milind is ready to contradict you all. He would say hysteroscopically has to be done by ambulatory or office. Thanks to Komal for having me here. And I hope I have done the justice and I've learned a lot from you all. Thank you. Thank you so much.
Thank you so much, sir.
Krishna Kumar sir, that was a wonderful moderation. Thank you, sir.
Thank you, everybody. Thank you, everybody.
It was really challenging mind also to think about various
I'm
factors.
sorry if I contradicted too many things.
No,
Sorry.
you're fine. I think you're being very practical and honest.
That is panel discussion. That is what called panel
That is
discussion.
panel, yeah. We had such experts, so we had to be practical. I can't be theoretical here.
Yeah, you were very
Okay.
practical. Thank you.
Thank you. Thank you.
So thank you so much, Krishna Kumar sir, and the esteemed panelists for being there. I think challenges are a part of our learning curve, and I don't think we ever stop facing challenges.
Right.
Whatever.
All the best. All the best to Komal for her
Thank you,
future,
sir.
all aspirations. All the best, and thank you. Thank you for joining. And
It was a lovely, wonderful panel, as expected, with Krishna Kumar throwing so many googlies, and everybody has done fantastic. Sir was saying that I am going to do seeing the panelists, I have to conduct a panel.
Raise my bar, yeah.
Yes. So it was really nice.
Madam, best luck to you.
Thank you.
Thank you so much.
Initially, when Chavan sir was there, he was having 2 coconut trees on the side, so I felt he was in Goa.
No, he's there. We have coconut trees in our compound. So
I think it was a virtual background, but I just felt he was in Goa.
I think thank you to everybody, all of the experts who have been here with us. They've shared their wealth of knowledge and experience. And I think all the beginners over here who have been there have benefited from all of this, all these troubleshooting tips and tricks that all of the panelists have given. Thank you so much, Krishna Kumar sir, for joining us today, despite all your busy schedule and conducting this wonderful panel.
Thank you so much.
We begin with our eagerly awaited talks. And for this session, I would like to welcome our chairpersons, Dr. Meenakshi Goel. She is a senior consultant, gynecologist, infertility specialist, and a laparoscopic surgeon from Hisar. And she's a consultant at Akarsh Gynac and Plastic Surgery Center in Model Town, Hisar. She is a member of IAG. And Dr. Shakuntala Kumar, madam is also senior consultant from North Delhi. And she has been trained in endoscopy from Kiel University, Germany. She is attached to various prominent hospitals in Delhi, and her interest is endoscopy, and she has been a faculty at various prominent conferences. We welcome our chairpersons, and of course, we have with us the office hysteroscopy expert of India, Dr. Milind Telang, and I must say that hysteroscopy has been my love and passion since I first saw it. And the one person I credit it to is Dr. Milind Telang. He himself is so passionate about hysteroscopy. He has instilled this passion in me of office hysteroscopy. I remember those days when he used to hold my hand and actually teach me the vaginoscopic approach. So thank you, Milind Telang sir, for agreeing to be here and actually spreading the word of office hysteroscopy. I mean, he's the first person to even recommend and encourage me to go to Dr. Stefano Betocchi in Italy. So, sir, you have carried the word of office hysteroscopy in India, and I would like to, in fact, request our chairpersons to formally introduce him. Thank you so much for being here.
Thank you. Good evening to all. Hi, Ridhima, and very good evening to Milind sir. It is a very proud moment to introduce sir, though sir doesn't need any introduction because sir has been a pioneer of hysteroscopy in India, and I knew sir, and he's an excellent hysteroscopic surgeon and a person too. Sir has done diploma in laparoscopy from Kiel, Germany. Hello. And sir has been had done fellowship in hysteroscopy from the Italy, specializes in fertility, IVF, endoscopy. Sir is running 2 hospitals in Pune for last 29 years. Sir is a part of Galaxy Care Hospital as IVF specialist. Sir has done so many presentations, video presentation at AAGL, member of AAGL in faculty for PG course on hysteroscopy in Vancouver 2019. Sir has been faculty at ESG Greece, and sir has also won the best video award. I think there are lots and lots of things that sir has done in the field of hysteroscopy, and added to that, sir has been the part of first uterine transplant in India. And it has been a great opportunity today to hear to the lecture.
Thank you. Can I share my screen? Thank you so much, Meenakshi, for the kind words. Thank you, Riddhi, for inviting me. Thank you, Dr. Komal Chavan, Niranjan Chavan, for having me to the task H for hysteroscopy. And I would like to just share my screen. Just 1 minute. Can we share it? No, it's not here. There's nothing to share here.
Yes, sir, you can share it, sir.
Yeah. I'll just try to share. Can anyone see it now?
So,
no.
No, sir,
No,
not
still.
yet. No.
No, I don't think so. Just 1 minute. Just 1 minute.
Would you like to share the presentation with the team so they can project it?
No. I'll just do it because it's. बंद करो. Sure.
Yes, sir. Now we can see your screen.
Yeah, just 1 minute. 1 minute. Yeah, I think so. Now you should be able to see it.
yes, sir.
Yes, sir. We
Yeah.
see the presentation.
Yeah.
We just
So-
need a.
It's okay?
Yes,
Yes, sir.
Yes, sir. You will just have to make full screen.
Yeah. So can I start? So once
Yes,
again,
sir,
a
can
big
you
thank
play
you.
the presentation full screen?
Yeah. I'll play it off. Just 1 minute. I'll just play it off. Yeah. Okay.
Yes.
Yes, sir.
So office hysteroscopy tips and tricks. Well, the previous the panel was good enough to get an insight into what hysteroscopy is in India. And the last part of it was to deal with the hurdles in office hysteroscopy, which is the favorite question of Dr. Krishna Kumar. I know it because we do the AHL IHG course together. So I know he always asks me this question, and his final question is, how much does it give you? So how much do you earn from it? So the questions are familiar, but I like to tell you that office hysteroscopy, ambulatory hysteroscopy, and outpatient hysteroscopy, though they mean the same, it has now completely changed because when you say that it always seems impossible until it is done. So when the panelists said it is not possible in India, well, when they start doing it, maybe 3 to 4 years down the line, if they make an effort, they will always say it is possible. Absolutely. The nomenclature had to be in place because office in USA is something different from office in Europe and office in India or Asian countries. So it was called office, ambulatory, or outpatient. But what I do, or what Betoki does, or what Attilio does, is outside the OR, no medication, and vaginoscopic technique. Now, when you say outside the OR, it can be in a clinic, it can be in a tertiary care center, or it can be an inpatient also, which is undergoing. So accordingly, since there was a confusion to bring everyone on the same platform, you see that the AHL, ESG, GCH, they came together and they tried to put everyone on power when you say office or ambulatory. And then they had 5-6 components. That is, how do you manage pain? Which place do you do the procedure? The length of the stay of the patient, the type of procedure, diagnostic or operative, and whether the hysteroscopic approach is vaginoscopic or by putting in a speculum. So they got these frequent questions to be answered and tabulated a nomenclature by which, though it is very difficult, if you go by pain management, it is level 1, level 2, level 3. Again, 3 is converted to A and B, depending upon whether you're giving oral medications for sedatives or you're giving parenteral. Then regional anesthesia is 4 and general anesthesia. So when I say office, it is level 1, no medication, no non-sedative medication given. When I say office, outpatient, or operative, well, office means here is when you're doing it in your small clinic, wherein you're consulting and there is a room created for doing office hysteroscopy. Now that becomes difficult in India because then you have to have two sets of equipment, one for the OR and one for yourself here. And then many people, they might do it, but they will do it only the diagnostic part of it. And you have various modalities now available for doing such things. You have a hysteroscope which can be connected to a laptop and you can record it, and you require just a gravity system for the fluid, and you can do minor procedures maybe that is in your clinic. But then you should have something to give to the patient, and when you have something, that is, if some people require some medication later on, then it is done in a hospital setup but outside the OR. Those who say that I do office in the OR is a way of learning, that is, they are going to go someday outside the OR. Because if you calculate the money lost in the OR, when you arrange for an OR in a big hospital, you have to book the OR, you have to book the anesthetist, you have to book the OT, the time spent by the patient. So it actually cannot be office. So office is the setup wherein the patient from the OPD goes directly to your place where you do the hysteroscopy and goes out from there. While in the operating room, we all know what it is. Similarly, they declared what is office, outpatient, ambulatory. Extended recovery means if you are keeping the patient for more hours in the hospital, that is but less than 24 hours. And the type of procedure, diagnostic, operative, vaginoscopic, or speculum assisted. Now, this is done because in US, you can give sedation, you can have the anesthetist in your clinic also. And this is being done by more and more surgeons now in US because the insurance is paying the surgeon more if he does in the clinic than if he is doing in the OR. And therefore, they are changing their way of looking at it. This is not the same way what we do in India. There's no insurance cover as of now. But if the FOXI, IIG, or all the associations come up together with the the industry and push for insurance, you can still get a daycare insurance, and that will be achieved as soon as many people start doing office hysteroscopy. One should understand, Krishna Kumar sir spoke about the uterus, its anatomy. Well, it's a cramped and dark space. It's an inadequate light transmission. There is bleeding because it can bleed, inability to distend, and therefore hysteroscopy took a backseat. It's a virtual cavity. We are opening up the two walls of the cavity to see within. And therefore, it took a lot of time. And it was only and only after urology resectoscope came into being that we tried to reproduce it into hysteroscopy. And so what happened is, from a Cinderella subspecialty, wherein it was not used by many, now hysteroscopy is the gold standard for evaluation of endometrial cavity. Why? Improved technology for better patient compliance and treatment. We accepted this technology. From big mobiles, we came down to small mobiles. We came from listening aids, which were big, to ear pods, which are small now. We accepted this. Why not in hysteroscopy? Why not from the traditional hysteroscope to the office hysteroscope? We came down from micro colpohysteroscopes to miniature hysteroscopes to flexible hysteroscopes. From endomats, we came down to endomats which are specifically used for office. And now today, you have what you call the technical revolution, that is the intrauterine tissue retrieval system, which can be used literally in office. And you will see the visual analog score, which tells us the pain felt by the patient is as equal to the first day dysmenorrhea. So for a first day dysmenorrhea, do you prefer to give anesthesia or sedative? So it is in our mind, and we see to it that it plays in the mind of the patient. So that is a philosophy which I share with you, that we have to remove our roadblocks and accept this day, and then we'll be coming to power with the world itself. So what is the first tip that I should tell you? Well, the first tip is having the right setup. Now, you're all welcome to Galaxy to see what we have created. This is what I saw in Bari when I was with Betochi, that you should have a separate room with privacy. There is no oxygen, no crash cart, nothing, only a washing area available for the scope. You should have a cart which has everything, the screen, the recording system, the cautery, you have the endomat, everything well placed, and you can have an electronic chair or you can have an electronic bed so as to move the bed up and down as per your ergonomics, so that to facilitate the entry into the uterine cavity. So this is what is extremely important. That first step, that is to create a setup which is comfortable for the patient, respecting her privacy. Ideally, it should be near the toilet so that the patient go and change. In fact, where I was in Bari, they used to never change also. They were brought in their clothes and they sat on the chair directly. Only thing is, after finishing the procedure, they went to the toilet for changing up. So the second important thing is what I always say, that the surgery is planned in the mind, executed in the OR. So if I know I'm going to do a polyp, I know the size of the polyp, then I should know the equipment which I'm supposed to use beforehand in office, because the patient is away. I cannot shout, sister, give me this, remove this. The patient will get disturbed. So you should have everything on the trolley for that patient and assemble and keep so that it becomes easy. So point number 2 is the right instrument for the right pathology should be kept ready. And I'll come to a point which will highlight how I select the equipments prior to doing an office hysteroscopy. So that is trick number 2 that I've told you. Knowledge of new generation scopes. The new generation scopes which we're using are the generation 4 and 5 scopes, that is the miniature rigid scopes. Flexible scopes are no longer used because they require a lot of maintenance. They can be used only with CO2. Vaginoscopic becomes difficult. Diagnostic is feasible, though the entry is very easy with flexible scopes. One thing they have to remember, that the scopes have to be oval to conform to the anatomy of the internal os. Even a small reduction, say 1 to 2 mm in the optical diameter, reduces the entire surface area by 50 to 75 and helps us entry into the internal os. Many people in the panel say difficult in entry. Well, I will solve your problems here and here. Specialized pumps in office you require. If you're just using the gravity method or a pressure pump, it will be difficult because these miniature scopes, if you see, have only 5 openings on each side of the outer sheath. They cannot effectively remove the fluid. And therefore, what happens is when you have a stenosed internal os or an internal os smaller than the size of the scope, the fluid does go in, but the os is not opening. So what do? You increase the pressure. You say, push fluid. When you push fluid, it distends the myometrium and the endometrial cavity, causing pain to the patient. So you should have active suction. Now, if you have to have active suction in office hysteroscopy, you have to have some form of endomat which provides you suction at that particular point so that you don't push fluid in and raise the pressure. So specialized pumps to deliver fluid at low pressure is a requirement. Now, what is adequate pressure is a big question mark. But I will say a practical point is that pressure sufficient enough for you to see the endometrial cavity completely and operate within a specific time frame. Now, you will say this is politically right answer. But yes, one has to devise, because we play with pressures. Sometimes it can be 200 ml of fluid that runs per minute with an mmHg of 100. Sometimes we raise it to 150. But equally, we have to see that the intrauterine actual pressure should not go above 80 mmHg. Now, this is very difficult to calculate. We had a very intelligent machine in the form of EASI, and it has to maintain absolutely. The reason why? Because it had 2 drums, one for the fluid to flow in and the other for the fluid to come out. And therefore, it is to help in calculating the intrauterine pressure. In fact, the device was devised in such a way using an intracardiac pressure monitor, which was put along with the scope to measure the intrauterine cavity. But there was some problem with the stores. They withdrew it after 8 to 9 years of use. Then you have the miniature resectoscope, 15 French and 16 French. Again, this can be used in office, but here you might require conscious sedation. Now in US, conscious sedation can be given in the office. For us, it's difficult to give it actually in the office. So this will be into the OR. This will be into the OR in India because sedation we cannot give in one's clinic. So that is one thing. But intrauterine tissue retrieval systems, definitely the 5C, the elite, they conform to the anatomy of the internal os and can be used in office or an outpatient setting. That is the advantage of the tissue retrieval system. So that is tip number 3. And here in this diagrammatic figure, you can see how to align the oval shape of the scope to the oval shape of the internal os. Now the internal os, if you see, is oval in shape, 4 to 5 mm. Now you will say why it is oval in shape. It is oval in shape because of the anti-version and the retroversion onto it. And therefore, from a round internal os, it becomes oval. Now, in an oval internal os, you cannot put a round scope. So all these scopes were devised in such a way so as to conform, so that just merely turning the cable onto the camera at the level of the internal os aligns the longitudinal axis of the scope with the transverse axis of the internal os and allows easy entry into it. So this is the trick that has to be remembered. Always remain in the center of the cervical canal. Another important tip, which never will be mentioned in books, is this is a 30-degree forward oblique scope. So it looks up onto the anterior wall of the cervical canal so as to get the internal os at the 6 o'clock position. That is very important for you. Unless you get it into that level or at the internal os at the 6 o'clock level, forming a crescent at the 6 o'clock level, it is difficult for you to move in. With a 0-degree scope, you can have the internal os in the center of your screen and you can still move in. It is an end-on vision. So this difference you have to know with a 30-degree and a 0-degree. Remember, the 30-degree has come up because you need not stretch the cervix to see the ostia. Merely moving the cable on one side makes you see the ostia on the other side, moving the cable to the other side, and therefore you do not stretch the internal os, causing the stretch receptors to be activated and causing pain. So that movement appears in your under anesthesia patients, wherein you have the freedom to move your scope anywhere without causing pain. But in office, you have to be very careful when you're doing the same. And therefore, the next important tip that I would like to mention is selecting the right patient for office hysteroscopy. See, diagnostic hysteroscopy with targeted biopsy becomes the first thing. So all your AUBs where you're suspecting endometrial hyperplasia, your suspecting postmenopausal bleeding with endometrial carcinoma, you can definitely do a targeted biopsy. Remember, you can do in C endometrium hysteroscopy. It is not prohibitive. It will not cause the cells to go into the cells will go definitely into the perineal cavity, but will not cause upgradation of the cancer. It has been mentioned by the FIGO. Also, the prognosis doesn't differ for the patient, so it can be safely used. Intrauterine pathologies, endometrial polyps up to 3 centimeters. As you increase your limit, you can go up to 3.5 because polyps are soft in nature. Some mucous myomas have a limitation of 2 centimeters. So that is more important because we calculate 2 centimeters on sonography. Ideally, a myoma is to be measured in the term of volume. A 2-centimeter myoma differs from a 3-centimeter myoma because myoma the volume increases exponentially. In retained products of conception, I will recommend, there was a discussion just before in the panel, wherever it is a failure of MTP, you should know on sonography what is the Gutenberg classification, which tells you exactly what is the vascularity, and type 1, type 0, type 1, type 2 RPOCs can be safely done. Type 3 mimics a AV malformation where you can wait for a few days more if the patient is not bleeding. You can do an MRI to rule out an AV malformation. And here in this type 4, it has to be done in the OR, wherein you will go with the resectoscope and with the blood, without the current, you will remove the RPOC, but at the base you'll have bleeding, so you can use the cautery at that particular spot. So only in the type 3, it will be problematic. 0, 1, 2 can be safely used, removed by hysteroscopy because it is the best way not to damage the other endometrium by doing any blind procedures. Intrauterine adhesions in office, yes, definitely. I recommend it because here the pain will tell you whether you are in the wrong plane. The moment the patient complains of pain, remember, you are missing the plane. Intrauterine adhesions are fibrotic in nature. They do not have nerve endings. Another important point to be remembered in office is that the nerve endings are never in the endometrium. The endometrium doesn't have nerve endings. It is only in the myometrium. So if you, with your pressure and with your movements, irritate the myometrium, yes, the patient is going to complain of pain. And the moment the patient complains of severe pain, your ego should stop and you should stop the procedure and push her over. So that is an important thing one has to remember. Other thing is in infertility, wherever there is RPL, that is recurrent pregnancy loss, septums, except in thick septums, where you, on the Doppler you have seen vascularity in the septum at the base, I will not recommend. You will require a miniature, rather what you call a mini resectoscope or a regular resectoscope where you have to cauterize, and then you might do it under conscious sedation. Pre-IVF evaluations, definitely you can do, no problem at all. We can also do PRPs in office, should not be problem. I regularly do. Miscellaneous displays IUCDs, don't try to do blind procedures. Post TLH wall bleeding, you can definitely do vaginoscopy, and with the 5 French bipolar needle, cauterize the current, you don't require admission. Post-molar pregnancy surveillance, and in virgins and adolescent girls. Vaginoscopy was discovered in virgin patient only by Betoki. He had a problem and how to negotiate, and it conforms to the anatomy of the hymen. The hymen is around about 5 to 7 mm in its opening, and therefore a 5 mm scope easily goes without traumatizing the hymen. So this is an important thing, knowing the right diagnosis. Proper pre-hysteroscopic imaging. What you want to do in office should be known to you. The size of the, so use your pre-hysteroscopic imaging, the Doppler, the 2D, the 3D. You can use all forms before posting us. So RPOCs, myomas, polyps. This is what we do before posting and counseling the patient. Even septums of this size, even correction of eye-shaped uterus, and even intrauterine adhesions, which you're seeing on a 3D here, can be corrected with. Then coming to the timing, post-menstrually 6 to 10 days is the ideal time, because the mucus is absolutely thin, the endometrial vision is very good, you have no risk of pregnancy, and the isthmus is amenable to your entry. So you have no difficulty entering it. There is no false negatives because you know the day of the cycle, and therefore you'll not miss out on any pathology. What next? And this is extremely important. I always tell the banks do KYC, we should do what is known as KYP. You should know to counsel a patient, and counseling a patient is your best ally, is an important trick. And how do I counsel a patient? I show them this diagrammatic representation, what I'm going to do, what you have as a pathology, and then how we can remove it. This is how we show on our screen what is the way we go ahead in removing a pathology. Even we go ahead and show the video. Here you can see an office hysteroscopy, my setup. I am not wearing a cap, neither a mask, only gloves. I am not changed into my scrubs. The patient has no intracat, nothing. Patient is seeing the screen. You'll see one of my assistants showing her the pathology, involving her in the screen and the talk. So this is the best way of evidence-based medicine, that the patient is been diagnosed on sonography with a particular pathology. You're removing it under vision so that she knows that the entire pathology is removed completely. And this is recorded and kept. And here you can see the easy endomat, which you were previously using also. So this is routine which we do for all our patients. So where is the problem? The problem is pain. Everyone said pain. Negotiating the internal os, you get pain. Myometrial contractility caused by distension, you get pain. If you are not in the center of the cervical canal, if you start pushing your scopes haywire, you're going to get pain. So low pressure and use of normal saline. Normal saline gives you better vision. The flow, it is continuous flow, so it comes out continuously. You can add a little bit suction so that you maintain the distension at adequate pressure so as to see. And these are the techniques wherein you can reduce the pain. Mind you, if you start moving the scope at the level of the internal os to one side and the other side, remember there's a fulcrum effect at the level of the internal os. And as soon as you move, the stretch receptors cause a reflex and cause pain to the patient. So you should be gentle in your movements once you cross the internal os. Coming to pain. So there are two sides of pain. The patient feels that I will have pain, and the doctor feels he may give pain to the patient. So I always quote, fear has two meanings: forget everything and run away from the situation, or face everything and rise. So choice is for you all listeners. I have taken this choice 12 years back. You can start from tomorrow and you will be successful. I can be definitely sure. But there is a very good, interesting study done by Clark in UK. And he said 1 hour prior, if you give NSAIDs, it decreases the pain during and after the procedures. So you can definitely give one NSAID, which the patient is not hypersensitive to, 1 hour prior, and take her into the office setup and do. So this is one. So we should remove our mental blocks first before attempting, and then counseling the patient properly will help you in accomplishing a good office hysteroscopy. So what is important to us? Vaginoscopy, no speculum to be used. That is most important. So learn the art of vaginoscopy. Go inside the vagina without catching the vulva. Mind you, catching, it's a no-touch technique. Don't catch the vulva to increase the pressure in it. Very rarely, if it is a pastureless vagina, you might, but that is a rarity. Go down. I'll show you the technique also. Use vocal local. Have an assistant at the head end talking to the patient, asking her about her family, her children, and see how she responds. You can use music. I've used music also on my mobile. Get the patient involved and understand the fluidodynamics, that is low pressure enough to open up the cavity. So what happened after doing this? 84% of the patients expressed satisfaction with the procedure and 78% state that the pain is less than experienced during menstruation. Now, this is what has to imbibe by everyone. Another important thing is your sister should set up the trolley prior to the patient arriving into that position. Don't try to assemble the scopes in front of her. Definitely she'll have a fear of her life that you're going to insert such a big instrument into the vagina and into the uterus. The right technique is an important thing. Raise your hand to go into the posterior fornix. Create a swimming pool effect in the vagina. The vagina doesn't, distension vagina doesn't cause pain. We know from obstetrics, it doesn't cause pain. As soon as you go in, then withdraw slightly as you see. Now over here, I don't do a pervaginal examination prior to hysteroscopy. If I see the cervix head on, it is a retroverted cervix. If I see the cervix lying in the posterior fornix, it's an anteverted uterus. Withdraw your scope, see the external os, and now start bringing your hand down. And as you get your hand down, enter the cervical canal. Here you can change the scope again, that is a cable again onto the 90 degrees to align with the external os to enter the cervical canal. As soon as you enter the cervical canal, one tip to remember, and you will never and never cause perforation. Look up to the anterior wall of the cervical canal. Never look in between or down. Look up. And as you progress ahead, automatically the internal os will come at 6 o'clock position in a 30-degree scope. Once it comes there, turn the cable onto the scope, align it to the transverse axis, and you move in smoothly. So this has to be learned by each one before coming in. Now the question is, if I have a stenosed cervix, what to do? And Stefano Bertocchi saw that 10,000 of his 31,000 patients had stenosis, and what he did is he graded them. External what he calls stenosis, internal stenosis, type 2, upper 1/3 of the cervical canal, type 3, and type 4 was the entire thing. And can this be dealt in office is the question. And these are the mechanisms by which you can do it. And you can see the video by that time also. Remember the fibrosis, the fibers do not have nerve supply and blood. So they don't cause pain. It is your movement that causes pain. So you can see the video here. You can use a grasper. I always go with a grasper in the sheath. I never get the grasper later on to open. Similarly, I can use the scissor. I can use the bipolar needle to cut. And over here, you see, I had to open with a grasper. There's a polyp. So use the slicing technique with the bipolar needle. You can slice the polyp into small pieces and then put your grasper in and retrieve once each piece gradually. Now with the advent of tissue retrieval system, you can do this in one sitting. That is the tissue retrieval going in. You don't have to remove the scope again and again and finish it off. So this was the technique which Bertocchi propagated, the slicing technique and removing. So if the pathology is bigger than the internal os, you can use this technique to remove it and still accomplish the feat in office. Targeted biopsy. Now there is a question whether I'll get an adequate biopsy. What is adequate biopsy? Again, Bertocchi has done a very good study wherein he showed the grasp technique with the crocodile forceps. When I open the grasper, it is 6 mm. I see the targeted area, I push the grasper ahead to erase the endometrium. Now, as you see in this picture, the tissue which is inside and outside. This is an ideal biopsy. And this, if I remove intact out, that is, don't pull the grasper into the scope, but the entire scope under vision out, you're going to get something like 5.7 mm square of tissue, which will be read by any pathologist. This is what we have trained our pathologists also to get a proper, and this you can have multiple targeted biopsies if you have multiple abnormal spots. Then supervised training. It cannot be. Hysteroscopy requires supervised. It cannot be see one, do one. It's impossible in any endoscopy. So you have to learn the art of the instruments. It is a man-machine environment, and therefore you should know your machine, how to use, how to assemble, how to have the right cortical settings, everything before you start going in. And that can be better when you undergo a supervised training and undergo the proper training to do office hysteroscopy. I always quote this: the ship is always safe at the shore. So you're always safe in the OR because you have an anesthetist, but that is not what is built for. So you have to come out of a comfort zone. You have a fear zone, but your learning and teaching will give you a growth zone, which you should come to. And this is how we did. There was Betoki who published 31,000 cases in his day. We did an attempt to showcase 3,000 cases, which is a published see and treat in Indian experience, which we have done. It is available for you to read how we have gone through it. We went a step further and we did tissue retrieval system in office and published a series of 84 cases, which we could do in office. So it is feasible. In fact, we even went to the Trocar journal, which is online, and how to remove cervical stenosis in office by tissue retrieval system is a published video article, which you can all avail. It's available free in the Trocar ISG journal by this name. I'll not show you the video right now because it is a big video. And then coming to the advantages. Well, it is very simple to perform if you master the art of vaginoscopy. It is under vision. So no chance of perforation, mind you. No chances of false passages. No anesthesia required, reduced cost, less load on the OR. Now, this is really important for you. Remember, when you say of economics, you don't lose money. This money is directly in your pocket. Quick recovery and return to mobility. And then the patient is your best ambassador to send you more patients. So this is how economics works for you. These 3 lines are helpful for you to have your economics in the right place. Definitely endoscopy setup is costly, whether it is laparoscopy, robotics, or hysteroscopy. It is costly. It is costly. But how to improve your load is doing this. Doing a proper imaging also helps you to come out and do proper hysteroscopy because you'll have more cases for hysteroscopy. And this is not what I am saying. The tips and tricks have also been mentioned by Attilio in his very famous publication, wherein he says small diameter hysteroscopes, use of saline solution as distension media, and vaginoscopic technique has contributed to this technique being accepted worldwide. India has a large number of patients who can be treated by office. I hereby say that each one should try office, come out of his comfort zone and try this process. And India requires, when in corporate or government hospitals we are doing free, it is better that we don't use anesthesia, don't put a load on the government and start doing more and more office cases. How to achieve perfection? Practice vaginoscopy in the OR first when the patient is asleep. Once you are very familiar with entering the cervical canal, then you can go ahead and start doing under sedation, maybe. And then once you're confident under sedation, when you can speak with the patient comfortably while she's awake, you then go on and start removing small pieces like taking a biopsy, remove ICD, small polyps, and then train your team. This is very important. They should know everything about office hysteroscopy, the setup. They're extremely important. Do proper counseling of the patient and use minimal distension pressure needed for adequate visualization. This reduces patient discomfort. Proper reporting, though it is not a tip and trick, but I would like to mention here purposely because it's a task. This will be seen by students. You have to report properly what type of hysteroscopy you have done, how much time it has taken. This is what we do. So we know what is the degree of pain, what is the duration in minutes we have done, which modality we have used, and we can jot down the entire findings so that the other consultant knows what has been done for the patient. And if you see this video, this is the tissue retrieval system in office where you can see an RPOC or a polyp being removed very easily. It is extremely time saving and It is a recommendation now, my dear. It is a recommendation. Tertiary units should have an outpatient department for office hysteroscopy. Level of evidence 2, strength of recommendation A, and therefore we should go ahead in bigger tertiary care centers to have outpatient clinics to help our patients do better with office. A few reminders. When we say diagnostic hysteroscopy under anesthesia, it is an anachronism. There's nothing like diagnostic hysteroscopy in anesthesia. Learn the art of vaginoscopy. It is a boon. Keep the pump. This is an important thing. Keep the pump 20 centimeters above the abdomen. When you use the gravity, we see it 90 centimeters above the pelvic brim. Always go with the grasper in. You will never find a problem with your pressure. Mind you, people first go with the gravity and then introduce the grasper. You will definitely have a fall in the pressure. So go with the grasper in first. You always go with less pressure. So you're comfortable with the opening with low pressure and you'll achieve success. Say no to DNC. Hysteroscope is the best way to evaluate endometrial cavity. That is, should be remembered by each and every upcoming gynecologist. It has to be in an armamentarium, the hysteroscope. I think so. I'll put a step forward. Linda Bradley said, hysteroscope, your stethoscope, but I say hysteroscopy of a gynecologist is his birthright. So he has to know hysteroscopy. He may not know laparoscopy, but he has to know. And this is how we achieve. This is for Riddhi. Purposely, I put this photo for her because she was there in this live workshop when we did 43 cases with Betoki in Galaxy, and none of the patients complained. You had so many people observing the procedure, and therefore, thank you so much for a patient learning. Thank you so much, Riddhi, once again for inviting me.
So thank you so very much, Dr. Milind. I am Dr. Shakuntala Kumar here. I have the privilege to be your chairperson. So
Thank you.
So I think you have given wonderful tips and tricks. And the most important thing that you have spoken about is a very important point is a pre-hysteroscopy imaging and proper evaluation of the patient. Sometimes you have a focal thickened endometrium. It may be just a thickened endometrium and not a polyp. So you have to evaluate the patient properly. Number 2, and again, very important point is a vaginoscopy. Vaginoscopy alleviates the element of pain when you're doing it properly and entering. The creation of a false passage is avoided, and you are able to enter without pain. And the patient is being involved in your counseling by visualization of the images, and the whole process is happening. I think it is a wonderful idea. And lastly, keep innovating. That is so very important. Once again, you have a thing like sometimes I'll share one experience with you that we had a very deeply impacted foreign body and turned out to be an IUCD. And when nothing helped, we just took a ureteric stone removing equipment. And, I don't even know the name of the equipment. And, my urologist said, my OT technician says that, madam, why don't you use this? And lo and behold, and we were dancing in the OT. I mean, it was such a difficult removal, but ultimately we could do it successfully. So keep innovating. That is very important. And lastly, keep, proper documentation. Proper documentation, medico-legally, is very, very important. How much time you spent and how much or what all you did has to be properly documented. So thank you so very much for all your inputs. You made hysteroscopy sound very, very methodical and yet very simple. Thank you so very much.
Thank you so much for having me here. Once again, thank you. Niranjan. Go ahead.
It was a very eye-opening lecture, but I just have few queries as your student. I'm asking, sir, what is your take on whether we should go for hysteroscopic removal of RPOC in every case, or what should be the selection criteria in which we should be doing hysteroscopy? And second question,
go ahead.
One more question, sir. What is your experience, sir? These two clear these devices, tissue extraction, they are 8 mm. As you have shown. So wouldn't be they requiring dilatation? So would it be possible to do it in office?
Yeah, I'll just go the reverse way now. I'll answer your first question, which will answer your the second question, so that it answers the first question. The True Clear tissue retrieval system comes as 5C. Now 5C is 5 mm. It is the smallest tissue retrieval system in the world as of now. All these are now they have come out. That is but fiber optic. So the vision is slightly weak, not good enough. So unless you are experienced, you might get slightly trapped. But it is purely meant for office because it has a continuous flow irrigation and you can see the tissue and remove it under vision. One. Having said this, they have come up with what is known as the Elite Mini now, which is 6 mm. Now 6 mm is equal to your mini resectoscopes. You are using mini resectoscope in office. The tissue retrieval system Elite can be, it's a rod lens system. So the vision is as clear as the Betoki 4 or 5 system. So vision is not a problem. Coming to the second or the first question, can you remove all RPUCs? Yes, you can remove all RPUCs by hysteroscopy. One. Secondly, type 0. One should follow the Gutenberg classification, which has been mentioned by Luis Alonso. It's available. It's a sonographic classification and its appearance on hysteroscopy. So type 0 is completely avascular and it is in the cavity. Now that can be completely removed by hysteroscopic morcellator or by hysteroscope. Secondly is type 1, which is mildly vascular, but still completely in the endometrial cavity. That is 2, that type 1 can also be removed. Type 2 is adherent and slightly increased vascularity than type 1. So the vascularity is different, but still no myometrial vascularity C. So when you get myometrial vascularity, you have to be cautious because the bleeding will be profuse over there. And then it will be difficult. So over there, you can use tricks like giving, say, methotrexate first, or you can use vasopressin, or you can simply, if the patient is not bleeding, wait for a few days. Give antibiotics, wait for a few days. By routine waiting of the patients also, you will have the vessels being blocked and you can remove it. But then in type 3, use a resectoscope. So that will be in the O1. You go inside, see the pathology, use the non-electrical loop, that is without electricity, to sense it out from the endometrium. And if you see electricity, to cauterize it. So this technique is used. Otherwise, we are using regularly tissue retrieval systems because the reason is very simple. Because, hello, can you hear me?
Ji, sir.
Can you hear me?
I'm so sorry to interrupt, sir. Sir, actually,
Yeah.
is it possible for you to answer the queries in the chat box?
Yeah. I'll do that. So you can carry forward with
We
the
have
talk.
yeah.
Thank you, sir, and thank you, Riddhi. It was a great.
Thank you so much.
Very good
Thank you
pleasure. Yes.
So sorry
much. Thank you. Yeah.
Thank
no
you so
problem.
much,
No
sir,
problem.
for being here.
And
And actually making office hysteroscopy, I think I've fallen in love with hysteroscopy just because of you. Thank you so much. And now an absolute privilege to have Dr. Noza Shariar with us today, my boss, my mentor, my forever inspiration. Absolutely multi-talented person, multifaceted person, from being a pioneer in hysteroscopy when hysteroscopy was not even a modality which was known to many. And he's been one of the most, I've seen him being the most patient obstetrician. He's an amazing teacher, mentor, and a champion for women's health. So, sir, it's an absolute honor for us to have you here talk about your love of hysteroscopy. And for your session, sir, I would like to invite our chairpersons, Dr. Amita Shah. She's a senior consultant from Gurgaon, and ma'am is the clinical secretary of Haryana IAGE. And Dr. Monica Singh, ma'am has been waiting here since the panel. So thank you so much, ma'am, for waiting. She's the vice president. She's the secretary of the MP chapter of ESAR and the vice president of Bhopal OBGY Society and the Bhopal Menopause Society. We welcome you, ma'am, and I request you to give a formal introduction of Dr. Noza Shariar.
Thank you, Dr. Thank you, Dr. Riddhi. And at the outset, I would like to thank Dr. Komal Chavan for giving me this opportunity to attend this beautiful session. And I've enjoyed the panel and all the talks. And now I am so honored to introduce none other than Dr. Noza Shariar, who we look upon as one of the pioneer gynecologists who has set standards for all of us to follow, and made India so famous the world over with his, awesome work. Sir has been the past Secretary General and past MTP Chair, FOXI, past President MOGS, He has worked in these reputed Breach Candy, Hinduja Kar, Holy Family Hospitals. He was the scientific chair, 22nd FIGO Congress, Rio de Janeiro. He has delivered multiple orations, many presentations, edited 5 books, published papers and chapters. He is been awarded FRCOG, AOFOG Young Gynecologist Award. He has also been awarded the Dr. Hansotia Best Committee
Thank you,
Award
Monica.
by Dr. Datta. I am so honored to introduce you, sir, and we cannot wait to hear you.
Thank you. Thank you. Could I please start by sharing my screen? Are you seeing my screen?
Yes, sir.
Yes, sir, we are able to.
That very handsome person which every gynecologist owes a debt to every day of our life, Victor Bonney. So Komal, thank you. It's always a privilege, lovely program. I've been enjoying listening on the panel discussion as well as Dr. Telang's lecture. Riddhi, thank you. Lovely program that you put together.
Thanks.
And for giving me an opportunity to speak on something that's really special to me, hysteroscopy. I love obstetrics. I love women's health. I'm passionate about contraception and induced abortion. But if there's one thing that I really live to do in gynecology, it's hysteroscopy. Theodore Munger said a purpose is the eternal condition for success. And, you know, there was a time, not so long ago, maybe 100 years ago, when fibroids meant hysterectomies. And then along comes this man, and there's a lovely story behind it, who gave us so much and so many different ways of dealing with fibroids or fibromyomas. And we owe debt to him. Today, I speak to you about hysteroscopic myomectomy, which is now the gold standard. I remember in the early 90s, maybe 91 or 92, I had a lecture I gave which said hysteroscopic surgery looking for indications. Today, I talk to you about hysteroscopic surgery being the gold standard for so many things. You can't do adhesions. You can't do submucous myomas. You can't do a septum. You can't do most Mullerian anomalies without hysteroscopy. You can't. Doing it any other way would be unethical. Well, you can do a hysterectomy differently, and that wouldn't be unethical. And a lot of other things we do differently, but not hysteroscopic surgery. I mean, I would have had a lot to discuss, but I'll tell you something quite interesting. We were doing outpatient hysteroscopies in Wadia Hospital in 1990 to 93 with a 4mm hysteroscope. Truly outpatient. It was in the OPD. There was no anesthesia. We had video endoscopy. I had a team of infertility officers working with me. I can remember Jaideep Tank and Kedar Ganla, who became so good at it. And just imagine now you got the better key. We were doing outpatient hysteroscopies for patients of primary infertility with a paracervical block, them watching the screen, and we were definitely doing it for other reasons. Of course, I must confess that we were doing second look scopies, and I do not believe I need to do a diagnostic hysteroscopy anymore. When you've got imaging, when you've got 3D ultrasound, I do not do diagnostic hysteroscopies. For me, hysteroscopy is when I need to correct something. And today I talk to you about the technical nuances and practical pointers. The one other thing I'd like to talk about, retained products of conception with medication abortion. Just leave them alone for long enough and most of them will clear. It is the type 2 and the type 3 that persist, which require your intervention. And that's where hysteroscopy probably again would be a gold standard. Now, all of us know that all myomas don't seem to be very significant. A subserous myoma probably has no significance on fertility outcomes. I have a series of over 100 larger than 5 centimeter myomas, 10, 15 centimeter myomas, and pregnancies go through well. Intramural myomas may reduce infertility, may increase miscarriage, but evidence is still insufficient. But submucous myomas, there is no doubt. Reduced fertility and increased miscarriage rates, and a myomectomy is likely to improve fertility outcomes. Today, we have a very clear classification of myomas. They both overlap, the FIGO and the Escheret, because the FIGO SM0, 1 and 2 are very much like the Escheret type 0, 1 and 2. The 0 is pedunculated intracavitary. The 1 is more than 50%, is less than 50% intramural, and 2 is greater than 50% intramural. And the one other myoma I'm going to highlight here, because it's going to be a part of my presentation, is the O8, because today we're going to talk about a cervical fibroid. Of course, you could also have hybrid leiomyomas, which bridge the entire wall. The ESG classification type 0, 1, and 2, pretty much the same. And the way they differentiate it is, if you have a less than 90-degree angle of the myoma surface to the uterine wall, then you probably have a type 1. But if it is a greater than 90-degree angle, then it is going to be a type 2. 1995, these were the years when people were wondering, myomectomy, interestingly, was one of the earlier procedures done hysteroscopically. But myomectomy, does it really make a difference? And this paper by Fari said that if you have a distorted cavity, normal cavities have almost the same implantation and other rates. The abortion rate was a little more, but a dramatically less implantation rate, less pregnancy rate, higher abortion rate, and a low birth rate with cavity distorting myomas. If you look again at the different myomas, subserous don't seem to have any impact. Intramural do have some impact, but the maximum impact is when you're dealing with a submucous myoma, and these definitely need correction. Now, these are my gods, my role models. It was the 1990s. I did my first hysteroscopy, I think, in 1988, 89, when I heard Alan Desherney, and we had Dr. Motashaw, and we had Dr. Khandwala being our Indian role models. And look at these, 24 cases Donne, 16 cases Vale. And they told us that if you do a hysteroscopic myomectomy, look at what the pregnancy and delivery rates are. What about infertility? For a long time, we were told that there was no evidence that was really high quality, which told us about hysteroscopic myomectomy. And this was an unexplained primary infertility in an RCT of 215 women. Submucous myomas, the sole cause, almost equal groups, no fertility treatment given. Study group where myomectomy was done, 63% pregnancy rate. Control group, yes, submucous myomas did also have pregnancies without surgery, 30%. They said you had better possibility of becoming pregnant after a myomectomy, and this did not differ with size, number, and location. So let's start with the FIGO SM0 ESG type O myoma. Firstly, let me be very honest here. All my work, I do use the Beto key, but you won't get a vision and a cut like this for a myoma of this size if you weren't using a resectoscope. Okay, let me put it out there first. And while I have used the bipolar, I'm still someone, and I heard some people saying that again, using unipolar, and I'm not afraid of it. And I think if you use it well, please note that little blood vessel that you're seeing. I'm going to talk about it soon. If you have this kind of a pedunculated myoma, do not go for the pedicle. You may fulgurate the pedicle with a roller ball to reduce bleeding. Do not go for the pedicle. Cut it down to a size that will be easy to extract. Dr. Motashaw told us right in the beginning about a case where she cut the pedicle and then the myoma floated around because electrosurgery won't work once you've detached it. And once you've brought it down to a reasonable size, then go for the pedicle and you'd be able to remove this quite easily. Resectoscope, and now I'll tell you about those vessels. After going through everything, the pressure bags and the endomat, I must confess that most of these cases I do with pure gravity. I'm happy to see a few blood vessels. The biggest mistake a hysteroscopist makes is to try and go for a completely white, bloodless uterine cavity. The moment you do that, your pressure gradient is towards the vessels and you could have a problem, mainly with a myoma where you would be opening up large vessels. So be smart, be clever, learn to master different ways of doing it. And remember the Latin dictum, non vi sed art, not by force, but by skill. Let's come to a FIGO SM type 1, ESG type 1 myoma. Now here there were multiple myomas. I had mapped them beforehand. And the first thing you do, and I heard a panelist saying that there is nothing like 3D ultrasound. Okay. I do not need to put in a scope to make this diagnosis. Interestingly, in this patient, I also have an HSG and I do those a lot. Watch those blood vessels. Don't be afraid of them. It tells me my pressure gradient is towards the uterine cavity. There were 3 submucous pedunculated, and after cutting it down to size, I've gone for the pedicle. And then there were 3 kind of intramural just butting into the cavity myomas. Usually go for the posterior ones first, because that's where the pieces will fall. I heard a panelist saying very well that don't keep going in and out as far as possible. Try and, you see, I've made that almost completely. The moment I've cut it, that little myoma has been pushed into the cavity, and you gradually go. And in this particular case, we got out 6 myomas. I had a second HSG of a normal cavity. At that time, we weren't using 3D ultrasounds. So I had to depend upon 2D ultrasounds. And this patient shifted to Bangalore, but went ahead to have 2 pregnancies, both of which she delivered normally. So resect the posterior first, incise the overlying capsule in sessile myomas. Tom Peters has said, under promise, over deliver. Be smart, don't get carried away, particularly when we are talking about doing large myomas. A single step myomectomy is possible in almost 90% of patients, almost all the type 0 myomas. Type 2s might require multiple stage procedures. Be prepared for this by priming the patient in advance. And very often the reason is if your deficit has gone to 1.5 liters, if like me, you're using unipolar cautery, if you are using glycine, don't be afraid of glycine. Use a pressure bag to collect. I always have the outflow connected to a suction machine, so I can play with the pressures by opening it and shutting as much as I want. And at every point in time, there have to be people in the theater, your anesthetist, who's watching deficits like a hawk and constantly writing it up on a whiteboard. Your chances of success are high, 88% type 1, 82% type 2, but be prepared and tell the patient, I might have to do a second procedure. If you can't finish it off in one procedure, big deal. Give her a GnRH analog and go back after 4 weeks. And trust me, the residual myoma will be waiting for you in the cavity. Haven't had to do one in years, but always be prepared for it. So what do you do here? If it is sessile, make an incision on the intrauterine dome. They recommend PGF2. I don't believe in it. I don't use it. I don't even use misoprostol. Instead, you could remove, when you remove your scope, you massage your uterus, or you can do what is called as a hydro massage, where you just inflate and deflate the cavity. And the trick is to stay within the capsule. In a laparoscopy, you incise the capsule, the myoma pops out. Here, if it's intramural, deep intramural, it may not pop out, but learn how to identify the capsule. The moment you do that, you stay within it, you see vessels, you fulgurate as you go along, and you can completely remove them if they are really large myomas. In this particular study, what depended was how much myometrium there was behind the myoma. Very important. If you don't have a mantle, don't do a hysteroscopic myomectomy. And what is the myoma size? So this is an SM2. This, you can see barely any part of this myoma is in the cavity. And from the diameter, you can see that it's a pretty large myoma, because this small dome is still pretty large. Make an incision, go in, it won't pop out really well, and start incising the myoma within the capsule. Do this extremely patiently. Every cut of yours is 5 millimeters, just remember, or less. You go outwards without making a very large defect in the endometrial surface. Okay, you can already see a bit of the capsule at the back. The bulk of the myoma is still inside. Avoid excessive procedures. I've already said that. You can see the capsule and how it looks at the back. You can see those few. When you're cutting the myoma, usually you won't have much bleeding. The bleeding comes when you come to the base of the myoma. So you can see partly where I'm seeing the myoma and partly where I'm seeing the fibers of the white capsule. and you move your instrument around in such a way, you can see right there at 12 o'clock, right in the center of the picture is the capsule. And I'm using that as a landmark. Okay, I always use a pure cut. I do not use a combination of a cut and a coag. I believe your electrosurgery should be doing what you need it to do. Okay, you can see the capsule now. You're gradually shaving it off the capsule. More and more myoma coming into the cavity. There you are. You're moving laterally now. Now the vessels start up, and you can individually start fulgurating the vessels with the coag current. That's the capsule. That's the myoma. You are shaving it off. And before you realize it, you've gone deep into this crater. Seems very large, but trust me, when you finish this myomectomy and you let the pressure go, that's the capsule. It's amazing how you will see this whole space closing down. And my friends, this is gravity. I'm not using pressure. Okay, I have my endomat, which I like to use when I'm doing quick stuff like a septum and stuff. When it comes to myomectomy and things that a hysteroscopist should justifiably fear, and I've even had an overload with a bipolar resectoscope. You can even have an overload with a crystalloid. So don't think overloads only happen when you're using, there's the whole cavity. That was the tissue we removed. This myoma was probably in the range of almost 6 to 7 centimeters, single sitting. I've just put a 20 cc syringe next to it for perspective. And finally, you clear your mind of Kant. And this was an interesting, many years ago, a submucous myoma in the cervical canal. Now, there's a lot of stuff you can do in the cervical canal by hysteroscopy. The only thing is be prepared for a very limited vision. Be prepared to make very, very small moves. This was a myoma which was partly in the wall of the cervix, partly you can see part of it is coming in. The same principle happens. Identify the cervical tissue at the myoma base. Here I must also tell you that when it comes to cervical ectopics, I don't think there's any better way of doing it than a hysteroscopy. We've got about 7 or 8 to date. And now for me, hysteroscopy has become the primary tool for dealing with the cervical ectopic, and patients can pretty much go home soon. And you can see that edge where the myoma's edge is seen from the cervix, and you've gone and completely stayed in, cleared it out, and you can. We've also dealt with myomas which are almost completely in the wall. And if I know where the myoma is and I have got an ultrasound mapping, I can actually go for it. Now, the one thing I'll request participants here is please understand that this comes at a later stage in your practice of hysteroscopy. I believe every gynecologist should be a hysteroscopist, but when it comes to the difficult adhesions and the difficult myomas, please wait to hone your skills to a certain level before doing it. Finally, Winston Churchill has said, if you're going through hell, keep going. And trust me, hysteroscopists do go through hell from time to time. Complications, primarily hemorrhage. And if there is a lot of hemorrhage and you can't see anything at some point in time, be patient, wait, do a bimanual massage. Obviously, by now, you've already given her tranexamic acid, and use an intrauterine balloon if at the end of the procedure you've got vessels. 12 French Foley's catheter, knock off the tip, put it in, but please don't over distend the bulb. Put in 5 ml. Wait, see if bleeding is happening. Make it 7 ml. At some point between 5 and 8 or 10 ml, the bleeding will stop. Do not go crazy just because the bulb has a capacity of 30 ml. I have known about a case many, many years ago where there must have been a perforation. There was bleeding. Another senior gynecologist stepped in, put in a Foley's bulb, thought that they solved the problem until they had to do a laparoscopy or a laparotomy. And there was this 30 ml bulb and the uterus was literally split in two. So just 5, 8, 10 ml. That's what a gynac uterus requires. Your red lines are increasing fluid deficit. Do not try and get into that. I'll hurry up and finish because you would be probably getting into deep trouble, or loss of distension and vision. If you're not seeing in hysteroscopy, please do not continue with the procedure. What can you do? An ultrasound mapping to see the myometrial mantle. There has to be adequate mantle. Definitely avoid over distension of the uterus. You could rollerball the base, and people have used vasopressin at the cervix. And when I first started my practice, I don't have it anymore. I used to have a needle mounted on my resectoscope through which I could inject the base of the myoma. Resect within the capsule and without hesitation, do a second stage with GnRH. Deficit measurement has to be adequate. For my diagnostic scopies, it's either the endomat or still the pressure bag. The pressure bag is great with a TUR set. Please, it has to be a TUR set. Don't use any ordinary kind of stuff. If you're using glycine, if you're using a non-electrolyte medium, up to 1 liter, get ready to finish. Start measuring electrolytes, 1.5 liters stop. That's how we do our gravities. I'm not exaggerating. It's not that I don't have an endomat, but if I'm doing a TCRE or a large myoma, I feel much, much safer with gravity. It's something I've mastered over the years, and I find my least deficits happen when I'm using gravity. If you have a problem, supplement oxygen. Please, no 5 and 10 milligrams of furosemide, 20, 40. You really have to get there to pass urine. Our patients are fortunately young, and unlike the TURP syndrome, respond well. If there is severe hyponatremia, give a 3% saline over 10 minutes and correct hypokalemia, hypocalcemia. Our patients correct while they are in the recovery room, where, you know, they have today got these little devices which can, this patient's sodium had dropped down to 107, not very accurate, but scary. She corrects before she leaves the recovery room because our patients are young. She throws out a liter or a liter and a half of urine and she gets better. Now, this is a red alert where you may suddenly, this was a very difficult case. Multiple myomas, had a myomectomy before. We had decided that we were to do a myomectomy and a TCRE for her. So I started resecting, and there you see, as you go in, more and more myomas are coming out. Cavity was vascular, cavity was quite distorted, and we were systematically going, as I told you, I go for the posterior ones first and then start moving laterally. Again, just to draw your attention to the fact that I'm happy to see these small vessels. If you're not seeing these small vessels, then you worry, not if you're seeing these little bleeders. And do not worry, it won't mess up your vision, because like one of the panelists rightly said, you've got the suction on at the other side. So you're constantly recycling the fluid. That's what Hallis did for us. Hallis took the urological resectoscope and made it our inflow-outflow resectoscope. Look at that myoma popping in. And this went on and it was going really well. There's that myoma in front. You can see the capsule. I'm also doing a TCRE for her. Obviously, there's going to be an element of adenomyosis, all going extremely well. And this was the TCRE part. Myomas coming in, somewhere you're seeing the, and that was it. So, and at some point in time while doing this procedure, that's what happened. Now, when this happens, I still had distension, but something was not right. Stop using the current immediately, went in to explore where the bleeding is happening from. Was it just a bleeder? And watch what I see. I actually see you are not infallible. You have to be prepared to accept that at some point in time, each and every one of us is going to have complications. I agree with the panelists who again said, I've had more perforations from my tissue retrieval using an ovum forceps than with my instruments. So I'm very, very careful while doing that, because sometimes you just pull out an attached myoma. In this case, we put in a stitch, we controlled it. Fortunately for a family was complete. Most of my procedure was over. We managed to close that rent, control the bleeding. I went back in. I was so confident of my procedure that I did put in a levonorgestrel intrauterine system. The patient has been amenorrheic since then. This was many, many years ago. She still follows up with me, and she's going to continue with the levonorgestrel intrauterine system. This was an analysis of a long time ago, but it reflects what kind of work we do. With hysteroscopic myomectomy, a majority of patients have a menstrual disturbance, menorrhagia or dysmenorrhea. Reproductive problems are in about 1/4, so don't overcorrect this when it comes to infertility, of which you either have infertility or reproductive wastage. After correction, we had an improved menstrual pattern in 92%. Nowadays, I do a TCRE, yes. Levonorgestrel intrauterine system is my preference, standalone. But if I have adenomyosis, if I have a problem, I do a TCRE, and then I put a levonorgestrel intrauterine system, and our results are excellent, and we are really excited about them. In the patients with infertility, we had viable pregnancies in 76. So I'd like to end by quoting our greatest evidence-based, should I say, ancestor, Hippocrates. The lesson from the great master was primum non nocere, first do no harm. You have no business to harm someone just because you're not good enough or skilled enough. I also believe that you have to be a hysteroscopist if you are a gynecologist, because there is no way of dealing with so many of the common things in our practice any other way. And you can't be depending upon someone else to do it for you. But the simple adhesions, the retained IUCD or a foreign body, a small polyp, and how you do it is your choice. I know we've been pushing the Betoki, but please, 4 millimeters is fine. We are dealing with the cervix which dilates to 10 centimeters when she is delivering. So I'm not afraid of dilating a cervix to 9.5 and 10 millimeters. It works great. And the big secret in hysteroscopy is if you have an intrauterine space-occupying pathology, that cervix will dilate easily. I've had 16-year-old girls with submucous myomas, dilator walks in. I've had elderly women with an intrauterine polyp who otherwise have a very atrophic vagina, dilator walks in. But of course, you also need to master vaginoscopy and the Betoki scope. So finally, I'd like to end here. Thank you very much. Thank you, Komal. Thank you, Riddhi. Thank you, audience. Sorry for keeping all y'all all here pretty late. I'm going to stop my share.
Thank you, sir. It was such an eloquent and such an eye-opening talk. I mean, after ages, I've heard such a grand hysteroscopic surgery talk, and you have taken us down to the basics. During the panel, I didn't speak out, but I'm also pretty fond of my 4mm Richard Wolf, and I'm not ready to give it up because the vision it gives is so panoramic, so beautiful as compared to the 2.9mm. So just one question I would like to ask, if Riddhi permits. We have time. Sir, you talked about injection PGF2 alpha, capoprost, during surgery when you're dealing with probably a FIGO type 2 with a large intramural element. So what time during surgery do you?
I was reporting on a paper in literature.
Right.
I don't use the PGF2. Yes. I have my own opinion about a gynec uterus. I do not believe a gynec uterus will respond to methogen or PGF2 or misoprostol when you're trying to dilate a cervix. So I know people do it. I know people have published, and God bless them. And having been doing hysteroscopies for, 1989 to date, I've done very well without misoprostol in every possible case. So I'm just telling you, do what you're comfortable with, but don't run with the herd.
Yes, sir.
Do Valsalva on the cervix. Extremely patient with your dilatation. You should not be using any force. Your dilator has to slip in. You can do it under ultrasound guidance if you have a doubt. I have far more respect for an intraoperative ultrasound than for an intraoperative laparoscopy. I don't think a laparoscopy helps you prevent a complication. A laparoscopy helps you diagnose a complication. You can't be doing both well, but an ultrasound sees where your dilator and your instrument is. And of course, I mean, for me, I finally pushed to get the Betoki in all the hospitals because I think it's fabulous. I think vaginoscopies, incidentally, I've done vaginoscopies with 4mm scopes 20 years ago. And if it's a young girl, you can still keep the hymen pretty intact with the 4mm scope. I mean, young girls have even been known to use tampons, but that apart. So I think it's fabulous. I think when it's difficult, I want it. I know there are cases in which now today I thank myself for having that narrow hysteroscope. But when it comes to the big thing, I want great vision. When it comes to a real myoma, trust me, you can't deal with a 3.5, 4 centimeter myoma with that tiny little resectoscope. You need something that kind of cuts through it and deals with it well. When you have a big septum, I mean, this controversy about scissors, I used scissors in 1992. I gave them up. I started having a massive scissor mounted on my scope in 1994, and I went to my Collins knife, and I will never stop using the Collins knife. And don't tell me about electrosurgery, because I've seen that you try and cavity healing well. When we did outpatient hysteroscopies in Wadia in the early 1990s, after a few months, we stopped because the septae were healing so well, you didn't even know this woman had a septum when you went with a scope again. And incidentally, when I did my first, we did our first lateral metroplasty, which was a term I coined around 1996 in Wadia Hospital in a workshop within 3 or 4 months of being reported. The report was a scissor. We used a Collins knife. I still have the videotape. That woman who had lost 3 pregnancies went on to have 2 full-term pregnancies. My worry is this procedure we call the lateral metroplasty has been misused and overused. And I feel guilty sometimes that I spoke about it a lot back then. And I keep telling people after all these years, 30 years, I've just done a few hundred cases. And when people tell me they've done 1,000 lateral metroplasties, I have a problem. For me, there has to be an HSG or there has to be a 3D ultrasound. There has to be no other cause of reproductive wastage. There has to be a very, very narrow cavity where she doesn't conceive, and I would then step in and do it. And I will do it reluctantly because I know that I'm doing something to a cavity that might potentially also mar the cavity. Do it with minimal current, do it with a pure current, do it with a pure cutting current, and don't overdo the procedure.
And I think, sir, you've had minimum complications with glycine because you
No. I've had complications. I've had complications with
But
glycine.
the gravity method, we are yet now, we should like take this
No.
forward.
See,
Riddhi, don't you think? Use gravity. Start using gravity. We people are always,
Madam, I'm blessed to see sir operate day in, day out with large myomas. I don't know how he does it. He makes it look so easy. He uses glycine and he has mastered gravity. I think it's an absolute delight and pleasure to see how he manages his inflow and outflow, and he makes it.
I'm in Mumbai.
So
I have to visit, sir.
So basically, no. I again come. Do what you're comfortable with. But remember, when you're driving something into the cavity and you're getting desperate and someone is pumping up pressures, or when you're running an endomat at a very high pressure, that fluid is going somewhere if it's not coming out. And we have to have, what should I say? We honestly have to have the insight. Surgeons very often don't have insight because we are so caught up. And it's always that Mount Everest. I'm going to race the weather and reach the top. You're not going to race the weather and reach the top. You'll die going on your way to the top. So you have to be willing to give up. And sometimes it's really great to have your associate, and I have Riddhi, and my associates are constantly told, they're given the power of whispering in my ear, Mount Everest, when I'm getting carried away. And I say, okay, maybe I'm doing too much. I think you should stop. And they're very polite. They make me look like I'm thinking about it. I'm not. But you always need to have someone there who also tells you, who has the power in the theater of telling you when to stop. An anesthetist who puts their foot down and says, you've touched 1.4 liters deficit, stop. No, I'll just do some more. Let me get to 1.8 or 2, stop. You have to have an assistant or an associate who tells you stop. You have a sister who just has to pull out the instrument and say stop. But I've had complications. I've had a patient who had a transient blindness because of glycine toxicity. We did lose a patient, a friend's patient once. That was a bipolar resectoscope. I believe it was an embolism, but they thought it might be a big deficit. By and large, you have to recognize it. You have to deal with it. Most of our patients do beautifully. Even if they've got a low sodium, they just bounce back and go home the same day. But that next case of mine or yours could be a problem case. So we can never let our guard down, even for a moment.
Truly an eye-opening talk, sir. I mean, forever indebted to you for, such enlightening statements and such guidelines, which will help us improve our practice. Certainly. Thank you, sir.
And sir, it was actually like grounded talk. I mean, people who do not have such hi-fi hystromats and all, they can still use gravity. So many people, they feel sort of disappointed if they cannot afford a hystromat and if they do not have it. And by seeing your surgeries just being done by gravity method, I think many of the listeners must have benefited and must have again geared up to go in for hysteroscopy. So that is one thing your talk has made that impact to all the viewers, I suppose. Thank you so much.
You won't be able to use gravity for your diagnostic scopies, even with the 4 millimeter. You'll need pressure. You definitely can't use gravity for a better key. You need to drive in fluid. Okay, let's be clear. There's certain things gravity can't do. Gravity will work with your large resectoscope. One thing that scares me is I've seen surgeons pumping in air to create a pressure to drive it down. I think the panel spoke about air embolism. If you are depending upon a human being to do something, there's always that one day when something will go wrong and someone is looking the other way and you'll drive 20 cc's of air into the uterine cavity and you've had it, because that was air embolism is the worst thing. Okay, we did our initial hysteroscopies with the Hystromat, which was carbon dioxide in Wadi Hospital for many years. We actually had it, don't need it anymore. But use what you are comfortable with. If you're using an endomat, don't use crazy pressures just because you want to see better. Don't use crazy flow rates. I mean, you can put liters into a peritoneal cavity, but you can only put 100, 200 to maybe 250 ml into a uterine cavity. A peritoneal cavity just balloons at minimum pressures, your 15 millimeters or whatever you want to do. A uterine cavity will need minimum 80, 90 to open up, probably 100, 120. The moment you go above that, you are completely changing the gradient from vessels to cavity to vessels. And thankfully in a septum, there's no time. In many adhesions, okay, by the way, intrauterine adhesions for me are the scariest hysteroscopic surgery, particularly severe Asherman's. That's where I've had my most complications. No matter how great you are, that's one place where you can get it wrong because you're sometimes operating pretty blind. And the very large myomas, mainly intramural. Rest of it is usually quite okay.
So when you are operating a cervical myoma, which is sessile, how do you identify the cervical tissue once you reach the base? Is it different from myometrial tissue?
It is different from myometrial tissue, but it's different from the myoma.
Yeah.
You saw there was an edge. You could actually see an edge. The same thing with the cervical ectopic. Initially, our cervical ectopics were when they were not diagnosed, when methotrexate had failed, where a patient started bleeding while methotrexate was given. We are told that cervical ectopics can be pretty scary. Now, if there is a cervical ectopic, I post her in an emergency for a hysteroscopic excision, excise it like you would excise retained products of conception. Be ready with your roller ball to fulgurate the vessels at the base, and you do similarly with a myoma.
So you still use monopolar?
Most of the time.
Right.
So I do. We've asked the hospital to get bipolars. I had a very dear friend of mine, Atul Ganatra. Atul and me did a lot of stuff. Atul swears by bipolar. So at Atul's hospital, we use the bipolar a lot for many things. I don't like the cut a bipolar gives. The way monopolar slices through tissues. It just goes through tissues. Bipolar still makes it look like hard work. It's struggling a little bit. The loops are too thick. Maybe at some point in time, bipolar will get better. I am completely open to using bipolar. But till then, and I did hear what the panelists said. After saying what they said, many of the panelists turned around and they said they still use monopolar and they still use the resectoscope.
So you use a
But do you think that medico-legally one can be caught if you're using monopolar and not using a bipolar?
There's nothing medico-legally that's
right.
I mean, then neurosurgeons, gynecologists, all those resectoscopes out there have immediately become obsolete. There's nothing. See, just because something else comes, what if you have followed your basic principles and been safe and made sure you don't create major complications, there is no guideline in the world which says monopolar is dangerous and obsolete and should be replaced by bipolar.
Sir, hysteroscopic oscillators are so expensive. Do you
I've seen them. I've seen them demonstrated, but I've never used a hysteroscopic oscillator. We are in India. Here I'm struggling to get better key to hospitals. I'm struggling to get a bipolar. Even in the corporate hospitals, I'm not going to ask them for a oscillator at any point in time. And you can do it so easily with other stuff.
So that's a message for all of us.
Excellent, sir, as always, actually. Such lovely discussion and a lot of insights into hysteroscopy and the way you do it, actually. It makes it look so easy with a lot of finesse and everything. So it looks very simple when you're doing it. And thank you. A lot of questions all the younger people have about small doubts. I think you have solved it so well. And you have made it so simple, learning from how you do it, learning by doing. That is the best thing.
Thank you.
Thank you, sir. Thank you so much.
It is always a treat to see your surgeries and always hear your lectures. It's every day for me, it's a new learning. Thank you so much for being there, and apologies for keeping you waiting for so long.
I enjoyed I enjoyed Dr. Telang's presentation, and so I did see his outpatient at friends clinics in the US. I did see it in the UK, and I definitely feel it has a place, but like he said, not really in the OPD. For them, it's in the OPD because insurance companies pay for it very easily. I can't imagine an Indian patient be willing to pay us our charges if we did anything in the OPD. I have had patients. Okay, I have done. Sorry, I have done PCREs 30 years ago. I remember there was a workshop in the command hospital in Calcutta in a very obese woman with a paracervical block. I remember doing one early in my days at BRC hospital, diabetic bronchial asthmatic hypertension with a paracervical block. You can do these things. Patients force you to be gentle when you're not using too much anesthesia. We've had patients of ours lying there watching the screen. And by the way, who says hysteroscopic surgery can't be done under a saddle block or spinal anesthesia? If you have a problem with GA, just give her a saddle block. We've got great anesthetists. She's lying there, position the screen so that she can watch the surgery. She's going to love it.
Thank you, sir.
Thank you.
And I thank Komal ma'am and Niranjan Chavan sir for giving me this wonderful opportunity. And thank you to our chairperson, Dr. Monica Singh. You've been really kind to wait back. And Dr. Jyoti Malik, she's been the co-coordinator. Thank you, ma'am, for all your help. And to the audience, of course, who all have stayed back with us. Thank you for making this a huge success.
Thank you so much.
Thank you, Dr. Komal. Yeah. It was actually because of you, we could learn so much. I mean, all the speakers were great. The panel was absolutely practical, and the two talks and Dr. Noza sir's talk, and I mean, it was actually an eye-opener. I mean, we do hysteroscopy, we do operative, but still, I mean, I felt like a beginner in front, I mean, listening to so much of knowledge from them. It was awesome.